Yep. So the committee meeting will be recorded and broadcast throughout Parliament buildings and online. Public gallery, everybody's very welcome. You're allowed to use mobile devices. The Wi-Fi codes are there. It's not permitted to take photographs or record any of the meeting. Apologies. We have apologies from Colin and Nuala. Okay. So, Chair's business. Can I just start, I suppose, the Chair's business with some sad news. The death of Tom Frawley, which was a big shock. I was in an event last night and was told about it. So I think everybody at that event was shocked. I think Tom was at a meeting all day yesterday. So I mean, he obviously was the chair of the Western Social Trust. I mean, I've known Tom a long time from going back from his work as the Public Service Ombudsman on the Policing Board, and more laterally within his role within the Western Trust. So, I mean, it came as a bit of a shock. So I just want to pass on behalf of the committee all our condolences to Tom's family. Second thing, the event that was at last night was the Robinson Memorial Hospital in Ballymoney had their AGM. So I got an invite to it. I just want to put on record at this meeting the thanks for the invite and pay tribute to the good work that hospital does with regard to patients. I mean, to me, it's an exemplar of neighbourhood model, all the things that they're doing in terms of the elderly people, keeping people out of hospital, dealing with frailties, dealing with mental health services, and all the other things that they do. So I wish them best and good luck in the year ahead too. This morning, myself and Alan attended, along with committee staff, a visit to the Men's Shed in Ballymoney. So can I thank those from Men's Shed who attended, and a special thank you to Ron for facilitating the trip. It was a really good opportunity to see firsthand the excellent work that Men's Shed are doing right across and how their approach supports the department's neighbourhood model. The visit highlighted the wide range of support and activities available to members, including exercise, mental health support workshops, social engagement and general well-being. So if members are content out of this morning's meeting, we would like to write to both the Department of Health and the Department for Communities to establish what funding is available to support Men's Shed's projects, given the valuable work that they do and undertake with regard to health, well-being, social inclusion and within the community setting. We learned today, because there was representatives from the Men's Shed Association of Ireland, that in the south both those departments do fund men's sheds in the south, and we also learned not too much money can go a long way within the setting of a men's shed. So if people are content, we will write to both ministers on the back of that. And then lastly, in terms of Chair's business, most of us were there at the meeting with the BMA this afternoon, just in relation to the doctors and consultant strike. So I'm going to ask if members that we write to the Minister of Health just to express our desire to see re-engagement between the union and the Minister, and that all efforts are made to quickly resolve that situation. Content with that? Okay, draft minutes. Can I refer members to draft minutes of the meeting held on the 18th of June, page 5? Everybody agree with those? Content? Matters arising? None? Okay, so item number 5, SR 2026, the Public Health Notifiable Diseases, Hantavirus Diseases Order, NI 2026. So at pages 21 to 29 of our main pack, we have the details. The purpose of the SR is to update the relevant section of the Public Health Act to make hantavirus disease a notifiable condition under that Act. The SR is subject to the negative resolution procedure. We considered and approved the proposal for this SR at last week's meeting. After taking evidence from officials, and the department laid the SR immediately for consideration at today's meeting due to the urgency as previously outlined. So the department has confirmed that there have been no changes to policy content since the SL1 was considered by the committee. Can I ask members to agree formally that the Committee for Health has considered SR 2026/121, the Public Health Notifiable Disease is Hantavirus Diseases Order NI 2026, and subject to the Examiner of Statutory Rules report, has no objection to the rule. Content? Thank you. SR 2026-122, the provision of health services to persons not ordinarily resident, amendment regulations NI 2026. The details for this are at pages 31. Purpose of this SR is to update the relevant section of the provision of health services to persons not ordinarily resident regulations NI 2015 to include hantavirus diseases. The SR is subject to the negative resolution procedure, and we considered and approved a proposal for the SR at last week's meeting after again taking evidence from officials. The Department laid the SR immediately for consideration at today's meeting due to the urgency previously outlined. The Department has confirmed there have been no changes to the policy content since the SL1 was considered by us last week. So, I am going to ask members to agree formally that the Committee for Health has considered SR 2026-122, the provision of health services to persons not ordinarily resident, amendment regulations NI 2026, and subject to the Examiner of Statutory Rules report, has no objections to the rule. Content?
Yes.
Okay, thank you. Item number 7, oral evidence from the Department of Health on safe and effective staffing bill. That's an overview, so we will welcome. Okay, so can I welcome Phil Rogers, Director of Workforce Policy, Professor Maria McElgorm, Chief Nursing Officer, Anya Morrison, Chief Social Work Officer, and Rodney Redmond, Head of Workforce Strategy. So you're all very welcome. Thank you for coming. We did receive some documentation from you in advance of the meeting, but I'm going to hand over to yourselves just to make some brief remarks, and then we'll take questions.
Okay, thank you very much, Chair, and thanks to you and the committee for the invitation. So we're just here to talk a little bit about our proposals around safe and effective staffing legislation. I think this is probably the first opportunity we've had to brief you specifically on the proposed legislation. I think it's probably come up in different sessions as one issue, but I think this is the first time I've had an opportunity to brief you, particularly on the legislation, the proposed legislation. So by way of background, colleagues will probably be aware the legislation stems from a commitment made in 2020 as part of the framework agreement that brought industrial action at that time to a close, that we would consider safe staffing legislation for nursing. Through early engagement in terms of that work and that commitment with stakeholders across HSC, it became clear that we needed to think about expanding that. And Minister Swan, when he was still with us, took that decision that the safe and effective staffing legislation should be on nursing and reflect the wider HSC workforce. So it has evolved into a whole system approach aimed at supporting workforce planning and the delivery of safe, high-quality care across all the professions within our public health system. Development of policy has been informed by a substantial programme of engagement and evidence gathering. This included, consideration of approaches adopted in other countries. Our colleagues in Scotland and Wales have already got legislation in this space. Engagement with internal and external stakeholders, including chief professional officers and our trusts. Also significant input from our trade union colleagues. The RCN, Unison and NIPSA have been particularly engaged with us in helping to shape the proposals and the plans. And obviously reviewing our own existing workforce planning practices and our current staffing methodologies with respect to those in place. We put out a public consultation in 2024, nearly said 2004, 2024, and sought views on the key themes to be included within the legislation. And I think it's fair to say that the responses that we got at that time were demonstrated significant support for what we were proposing. Stakeholders, I think, have recognised the importance of having a statutory framework that provides assurance around staffing and workforce planning while acknowledging the realities of delivering care in a complex and often unpredictable environment. As I said, broadly the proposals that we put out for consultation have been accepted or been supported, and trade unions, as I said, played an important role throughout the policy development process and have been actively involved at all stages, really taking that co-design approach to developing the legislation. Obviously there have been some views in terms of specific aspects, so it might vary, but I think broad support for the overall direction of travel and for the introduction of the legislative framework that we're proposing. So one of the most significant conclusions, I suppose, from the evidence and the stakeholder engagement was that the legislation should not be based on fixed staffing ratios. Ratios can provide a simple benchmark, and stakeholders express concerns that they can lack in flexibility, so we have not proposed to put fixed staffing ratios within the legislation, although they will be used, and Anya and Maria might talk a little bit about some of their work that they've been doing in that respect. Instead, the approach is more centred on creating a legislative framework that supports safe and effective staffing and workforce planning, and the approach seeks to balance accountability and assurance with the flexibility needed to deliver services safely and effectively. So our aim is to introduce the bill to the Assembly following the summer recess. Excuse me, and obviously that will be over to yourselves then for the scrutiny stage to commence, hopefully in September, October 2026. And again, as the legislation develops, we'd be hopeful for continued engagement with stakeholders to continue to ensure effective implementation and operational readiness across the system. So just in closing, legislation is fundamentally about improving outcomes for patients, service users and staff, seeks to provide a consistent statutory framework that supports safe and effective staffing decisions across HSE. Ultimately, the objective is to ensure that the right people with the right skills and right training are in the right place at the right time to deliver safe, high-quality care, and that's obviously consistent with our broader workforce strategy objectives. We welcome the committee's views and look forward to discussing proposals further. And just to say, we thought it might be useful, and well, Maria and Anya have joined us, is they can talk a little bit about some of the practical work that they've been doing in nursing and in social work to, I suppose, prepare and get ready for the introduction of the legislation.
And apologies, Andrea hadn't you my list, so we also have Andrea Owens, who's the policy lead within the department on this issue. You're all very welcome. So thank you very much for that. So I'm just even thinking in the last 2 weeks I've met with representatives, nurses, psychiatrists, doctors, midwives, and all of them in the context of those engagements are talking about severe workforce pressures, issues, short staffing. So how is this safe staffing bill going to, in real terms, improve the levels of staffing, not just within those spheres, but right across our health and social care sector, and allow? I mean, how is it going to? How are you going to get to the levels of a safe staffing level in terms of recruitment and retention, given all the issues that we're currently exposed to?
Mm-hmm. So, what this legislation will do will put a duty or a requirement upon trusts, as obviously the people who are delivering and other arm's length bodies, to safe and effectively plan their staffing. What we will be requiring them to do from this legislation is that, and I think the best way to think about it is to work out how many people they should have in a particular setting, tell us how many people they do have, and then what actions they are taking to address that. So at the operational level, that's what the safe and effective staffing legislation will do. It will require trusts to effectively plan, working out how many people they need using tools or whatever mechanisms are best placed for that particular setting, and it will be by setting.
Yeah. So, sorry, I'm just going to keep interrupting here. Something
okay.
got onto my head, so apologies for that in advance. But so, in the legislation, there's not going to be any figures. There's not going to be, we need this. So,
and I think, if I may, I think if we were to put figures in the legislation, practice changes. What is required in a particular situation might change over time as services evolve and as practice evolves. So to put figures in the legislation would almost bind us at an early stage to say you must have X number of people in this service, when actually that service might change, and actually in 10 years' time you might not need as many people, or you might need more people.
So the legislation will be produced. Will figures go in guidance?
The legislation will require trusts to effectively plan and provide us with, or report to the department,
Okay.
like I say, across different settings, how many people they have, how many people they should have, and what they're doing to address the gap.
Say, for example, we did a meeting just a couple of hours ago with consultant doctors, and in the course of that meeting, we were told that there's 75% vacancy for psychiatrists within the Western Trust. So, how, I mean, for like that was a figure that shocked me, and how this legislation will, the trust and the Western Trust will come back and say this is the level. But how will they recruit? Where will we get the staff, given that there's current conflicts nearly with every level with regard to pay, with workforce, with people leaving. So I suppose the question I'm getting to is, we will have a piece of legislation. How much does the department envisage it will cost in terms of going from where we are now to having levels of safe staffing right across every aspect of our health service? And has the department budgeted for that? Because if you take that one level of 75% vacancy and multiply that right across, that's an awful lot of vacancies.
Yeah.
6,000 nurses, I think 6,000 potentially nurses, I think we were told, 6,000 staff across healthcare is a figure that's just popped onto my head.
There's probably a couple of things I would say in response to that. I think when we look at our macro figures, we are seeing growth across the HSE workforce. So we see more doctors, more nurses, more social workers across HSE, and that pattern is consistent and has been growing year on year for a number of years. We do recognise, I think, that there are some specific examples, and that might be by location, or it might be by speciality, or in the case you're example, by location and speciality in psychiatry in the Western Trust, where there are challenges in terms of recruitment, or perhaps in terms of retention. So in terms of what this legislation would do, the Trust would be, as I said, they would be telling us how many people they should have in that service, how many people they do have in that service, and how many people, and what they are then doing to address the gap, what actions they are taking at an operational level to address the gap. And some of that might be around recruitment, some of it might be around retention, some of it might be around doing things differently and maybe reconfiguring services, so that they can deliver the same service but in a different way.
And just to use this example, once this legislation is passed, the Western Trust will come to you and say, here's what we believe is a safe staffing level for psychiatry within our trust. And if it's 10 off the top of my head, well, if they only have 5 there, and over a period of 6 months they still only have 5, what happens to that service if it's been deemed to be unsafe?
Well, Mary might come in, but I think in that case, obviously, the Trust will be, the vacancies that they are articulating will probably be being filled by locum staff. That's usually how this is working at the minute. But what the legislation will require is the Trust will have to come with an action plan that says, this is what we're doing to address these gaps.
Okay. Last question for me. We're kind of mirroring or taking the example of Scotland. So in terms of learnings from there, have we anything that's positive, negative, anything standing out?
I think we Scotland, I think, went first in this, and then Wales have also moved in terms of safe and effective something. Certainly we influenced. We looked at what they were doing in terms of their legislation. I think in some ways ours goes a little bit beyond that, and maybe bring Andrea in to just say a little bit in terms of about what we would do, or what we are doing or proposing to do if the legislation progresses, and what colleagues in Scotland do.
Scotland initially was introduced before the pandemic, so their systems have obviously changed a lot since the introduction. So what they're finding, certainly in the first instance of their reports coming through, is that they weren't in a ready stage. So there's been a lot of criticisms at the fact that they didn't have the systems, they didn't have the learning. So that's what we're hopefully learning from them, is we're trying to have that in place before implementation. So that's why we're working with our colleagues at all levels to try and get ourselves ready. I think we're into the second batch now of the Scottish reporting, so we're starting to see their improvements, but it's definitely about readiness, and that's the thing. They also have in their legislation, they have specified the common staffing methods, but it was mainly for nursing. Where we're allowing that to progress is we're giving it more of a professional judgment for the professional leads to determine what is best for them, rather than saying this is what you should be doing.
And is there a danger? Is there a danger in the method that we are proposing, where that allows a professional judgment to lower a figure based on the reality rather than a specification?
There is the danger, but any decisions that go outside of the evidence have to be justified. So whether that be in a report to sort of the strategic oversight, or certainly by exception, as we've said to yourselves, once a year we're reporting on exception. If something goes beyond what the legislation is saying, there has to be a reason for that, and it has to be evidence has to be provided as to why that judgment went this way whenever the facts and figures told us to go another way. So we are leaving it a bit more flexible for those that are clinically prepared for these kind of decisions.
Maybe if you were, well, Maria and Anya might speak a little bit to that question, if that was...
And just before Anya, you come in, because we obviously have done the adult protection bill, and part of that is a very big concern that we're bringing in a piece of legislation that we may not have the social workers to implement. So it's very useful that you're here. Actually, maybe you can talk to that too.
Yeah, so I suppose in response to that particular bit, we've had an extensive programme of workforce reform ongoing for a good 3-4 years now. While our workforce position is still vulnerable, we have made significant strides, and you know, we need to keep on that trajectory to continue to improve. But we do have plans in place. In terms of new legislation, yes, there are a number of pieces of new legislation that will put demand on the social work workforce, and they will require funding both of the staff, but also in terms of training places and people coming through so that they're there. So in some ways, the safer and effective staffing in social work, it's very much linked to a number of our workforce reform projects as well. And in terms, for example, you know, our training places, the things like the Adult Protection Bill are calculated, you know, in our judgment about how many training places we need. In terms of this in particular, I mean, we have produced guidance, so which is this safer and effective staffing in social work. So we've been working on this probably for a number of years. We started with academic input from Queen's and UU to look at the evidence base in relation to safer staffing, see what models, what other models were out there, and also to try and put together a sense of a sort of metric and a tool that would work for social work, and you know, the particular circumstances in which social work work. We then moved on to well, we have engaged, and as Phil said, certainly at the social work level as well, we've engaged very widely with trusts, with NISC, with BASWA and NIPSA, you know, so to discuss and understand social work caseloads and workloads. So what we're hoping with this, this makes recommendations in relation to workforce planning, caseloads and workloads for the social work workforce. And a lot of it is applicable to any field social work model, people working in a team that who have a caseload. We have made caseload range recommendations. We've gone for a range just to allow for, you know, complexity in individual cases as well. So, and we have calculated recommended caseload ranges in older people's mental health and in children's service to date. This year we're starting to work on other programmes of care as well as children's home safer staffing guidance should be, we're hoping to have it complete in the next couple of months. We're also working on workload recommendations for team leaders as well. What we are doing at the minute is, so the guidance was issued to trusts in March 2026. It was issued with the, you know, a full full implementation wasn't possible at present, although there are many things within this that can be implemented without funding. They're about professional practice. We have placed the emphasis in this on collaborative working in and around allocation, grounding the decisions about caseload and workload very much in professional social work supervision. So it is a model that recognises that that a lot of this needs to happen actually at team level and between a team leader or a senior social worker and their team. Initial feedback is that we are close to the recommended ranges in some teams, albeit that a proportion of those that is probably being achieved by having waiting lists. There are other teams where we have a lot more work to do. What we're doing at the minute is we've gone out to trusts. We've held April and May. We've held 20 safer staffing familiarisation events, 5 in each trust, and they've been well received and well attended by senior managers, team leaders, senior social workers. The exercise we're engaged in at the minute is what we're calling an assess the gap. Surveys have gone out to all teams that employ social workers, asking about information about team structure and team composition, but current caseloads, any waiting lists or unallocated cases. And we're hoping that we will be in a position to analyse the results of that over the summer. And then we will move on to an implementation plan about, okay, so here's the gap, what is it that we need to do? And as I say, I anticipate that there will be demand for increased social work, but I don't believe all the demands fall into that space. That there could be things about skills mix. It could be just about practice within a team as well. And quite a lot is about professional practice here as well. So I would hope we would move very quickly to the things that trusts can implement at this stage, and then that we work out a plan which will eventually need costed as well about any of the gaps which do require more social work resource. So I suppose that's an update on where we're at and what progress we're making.
Thank you.
So if I just give you an update in terms of nursing and midwifery, and nursing being the biggest workforce within health and social care. So you will be aware that Minister launched the refreshed Delivering Care Policy for Workforce Planning for Nursing and Midwifery in March this year. There has been a framework for nursing and midwifery, the previous Delivering Care Policy from 2014, and there were several workforce reviews done across different services, and there was an investment in increasing the workforce at that time. Because there has been changes in population growth, different demands from the population, but also the need to ensure that we've got safe, effective staffing and the right skills in the right place. When I came into post, I asked for a review of the framework at that time. That was led by one of the executive nurse directors within the trusts, and also with one of my officials, and Phil was involved in that work as well. There was wide engagement with staff on the front line, service managers, people that provide service, and the Royal College of Nursing. The refresh framework is designed to be flexible and responsive to population health need, and that picks up on some of what you're saying in terms of, as our population changes, our workforce needs to change and respond to that to be able to respond to those needs. The refresh framework strengthens guidance for trusts and commissioners on workforce and workforce planning across the nursing and midwifery settings. It supports a culture of safety, improves staff well-being, and promotes a more evidence-based approach to determining staffing levels. Overall, the refreshed framework aims to support high-quality care across both hospital and community settings by strengthening consistent and system-wide approaches to nursing and midwifery workforce and workload planning. It also sets out a very clear accountability structure from ward to board in terms of workforce planning and roles and responsibilities associated with that. That's quite different than the previous process, but very much aligns to the preparations that were put in place for safe staffing in Scotland. The other aspect that we have included in the Refresh Delivery and Care, which people have mentioned already, is the combined staffing method. The implementation and development of the common staffing method includes the use of appropriate evidence-based workforce staffing tools where they are available. Now, they're not always available, so where they aren't available, professional judgment and local context does need to be taken into consideration. The tools can be used to assist assessment of nursing and midwifery workforce when taken as part of a triangulated approach to support the delivery of safe and effective care. And when I say a triangulated approach, we don't only just look at the workforce numbers, we look at the quality of care, the demand for services, the complexity, and all of that is taken into consideration in terms of determining what staffing levels are. I think that's particularly important when we look at our use of agency across the system at this time, that we actually really do this very effectively in terms of safe care. I'm very aware of the challenges that nurses are facing and midwives on a day-to-day basis with corridor care and a high demand, and that's not something that's quick to resolve, but having good effective processes around workforce and workload planning for nursing and midwifery is essential. We're taking a once for Northern Ireland approach to decide on the most effective and appropriate workforce tools for nursing and midwifery, and the RCN and RCM are fully engaged with this in that process. This will allow benchmarking and reduce unwarranted variation, supporting utilisation of workforce to ensure that we have the right staff with the right skills in the right place at the right time. The Refresh framework will strengthen guidance to our provider organisation and commissioners to ensure that effective workforce and workforce planning for both nursing and midwifery is embedded in practice, promoting a safety culture and upholding the well-being of the population. This is also supported and needed for transformation, and we do need to transform our services, and that's set out in the reset plan, so we have absolutely fully embedded that in terms of the delivery and care going forward. The common staffing method provides a consistent approach to aid clinical leaders to understand and evidence the staffing requirements of their healthcare setting, so it provides a very clear framework that can be used by everybody, so we're getting the same approach by everybody every time, and reduces variation in terms of effective workforce planning. It has a triangulated approach, as I've said previously, looking at safety and quality outcomes, professional judgment, the utilisation of evidence-based workforce tools appropriate to the area and where available, an understanding of the actual funded staffing versus actual staff imposed, and that's critical to what is your funded staffing to your bed complement, and have we got a consistent approach with that across Northern Ireland, and how do we measure and capture that in real time. Consideration of the local context, demand and complexity, capacity and working environment, ownership by teams delivering care and providing service. As part of the common staffing method implementation, we are providing webinars which will start shortly for all nurses and midwives from band 7 upwards, which is at team leader level. This has been provided from colleagues in Scotland who are very familiar with this, and we're also developing an animation so that all staff can engage with this process and become familiar with the common staffing method. A population health approach relies on data-driven decision-making based on the foundation of robust integrated data encompassing workforce demographics, cost implications and patient care activities. Applying a triangulated approach supports the delivery of safe and effective care by ensuring staffing levels are responsive to patient demand and acuity, and that is really important. And that includes the skill mix within this system as well. As the final part of this, just before I finish, is we've also, across the region, all trusts now have the same e-rostering system. We have started an e-rostering group, again, a once for Northern Ireland approach, so that we reduce variation across the different trust areas and have a more consistent approach. This by establishing consistent data definitions, standardising reporting, and integrated rostering practice to ensure that good effective rostering, because that's really key if we're trying to reduce reliance on agency, etc. That will be implemented fully and at once approach for Northern Ireland by the end of March this year. So that work is progressing. And finally, we have this year we have actually purchased the licence for 5 safer nursing care tools. These have been procured for 24 months and they will be rolled out across the whole of Northern Ireland within all of the trust areas. The workforce assessments using the evidence-based tools will run twice a year, and that will give us real-time data. We will also be able to get real-time data on workforce, including the utilisation of agency and why, from the e-roster system, which eventually will then need to link in with EQUIP. All staff are being trained, all Band 7 staff and workforce leads in nursing and midwifery will be trained in the tools. This work has already started. They'll also be trained in the 6-step methodology for how you assess your staffing levels so that there's a consistent approach. And finally, we have just introduced the Nursing and Midwifery Band 7 Toolkit, which helps ward managers and the team leaders and teams to actually understand clearer about their roles and responsibilities, and it focuses on personal leadership, team leadership, quality and safety, and effective management of resources. So that's where we are in terms of nursing and midwifery. For midwifery, we currently use the Birth Rate Plus. That was last done in 2022. That tool has actually been reviewed at the moment across the UK. So we're waiting for the outcome of that before we redo it in Northern Ireland, but that will be part of the implementation of the REMFU work going forward. So happy to take any questions.
Okay, thank you very much, both of you. There's a lot.
Just to summarise all of that quite quickly, I think what we've learned from Scotland is be prepared for implementation coming, and the work that Anya and Maria have outlined, I think, is the preparations that we are undertaking in their respective professions.
Thank you. Just going to start going around the room now, Diane.
Thank you, Chair. So, and I note that you said that, and it's in your briefing paper, that you have met a number of the trade unions and that played an important role in formulating this legislation. When the Royal College of Emergency Medicine were here, I asked them, had they taken part in any discussion with you, and they said no. Today, we have all received a letter from the BMA. Sorry, I should have had this up. Apologies. Oh, Alan has it. We've all received a letter from the BMA which says, I'll just quote directly from the letter, "We've had little meaningful engagement with the department specifically on this bill," indicating this would be a useful update. So, I mean, I think there is a gap here, clearly, from what people are telling us. And the BMA are also saying that while they're supportive of the bill, I think it's the intention of the bill is right. While they're supportive of the bill, they have concerns about the timescales and whether there is sufficient time to complete the legislative passage of the bill. Just if you want to comment on it.
Yeah, so certainly, as I said in my opening remarks, we did put the proposals, the policy proposals, out for public consultation, so everybody would have had the opportunity to engage, and we had very good engagement across Royal Colleges. It's unfortunate the Royal College of Emergency Medicine didn't get hit by that, or weren't able to respond to that. And similar with the BMA, I think we're open to talking to all trade unions in terms of the bill and how it might progress. I'm encouraged by the fact that they say that they're supportive of the direction of travel, and certainly I think the concerns around the timescales of progress, I think we would share them. We're trying to get this through before the end of the mandate. That's where we hope to have it to you as early as we possibly can in September, so that for the processes then that you need to go through. But we're hopeful that working together we'll be able to progress that through, and certainly I think both yourselves and certainly in the department would be willing to speak to the BMA and understand any concerns they might have and see if we can't address those.
Well, I mean, Phil, I don't want to labour this point. I raise it because it was raised with us. Each one of us received the same email from the BMA today. And they talk about little meaningful engagement. Safe staffing is a huge and important issue. And therefore, I do think it's incumbent on the day when we have consultant doctors on strike that we actually do engage with people and ascertain their views on such an important issue. I don't want to go further with it, but I do think it is a huge issue.
It's just so, as I say, we did the public consultation and it would have been issued to the BMA and they did not respond to
Sorry, they responded to the consultation. They didn't respond to a meeting request prior to the consultation going out to ask for their opinion on the consultation.
So rather than prolong this, my advice, for what it's worth, is to talk to them. That's. I just want to leave it there because I do think it is actually important. In relation to the bill itself, so the chair asked would there be any sort of figures or anything in the bill. Is this sort of almost like a framework bill with very little information in it and everything to be done by regulation? We're not overly keen on leaving everything up in the air, particularly on such an important issue.
So I think the straightforward answer, yes, it's a framework bill.
Yes.
It's setting a framework within which...
the bill, as you're proposing it, will be a series of frameworks, but it will not be detailed. How are you going to work out the detail?
The detail will be worked out, as Anya and Maria have outlined, in terms of the guidance and whatever that will be produced to support the introduction of the bill. I think in many ways, there will be requirements in the bill. As I said at the outset, we will be requiring trusts to report how many staff they have, how many staff they should have, what they're doing to address any gaps. There'll be requirements placed on the commissioners at a regional level to take that information and come up with proposals and plans at a regional level to support us. And then there'll be the work that we'll do in the department in terms of strategic high-level planning, looking ahead and saying, okay, all of this information we're getting, what that means for us in terms of commissioning places or whatever. I think I often talk about this bill being, it'll put a legislative framework around either what we are doing already or what we should be doing better, essentially, which is workforce planning. It's about workforce planning. It's about us knowing how many people we have in different settings, how many people we should have.
With the greatest of respect, since I've come back to this assembly, we've talked in the Health Committee about workforce planning. That honestly, I mean, with the greatest of respect. And a framework bill that doesn't give us much detail is going to be years before there's any implementation of it. And I know in the period, in the time that you have left, there's probably not much more time for anything more than that. But I think that'll be disappointing to people who are eagerly looking for guidance on safe staffing. I have nurses who call my office and say, I had so many staff on last night, but I work in a ward full of very complex patients. And while I had the required number of people, I didn't have the required expertise. That's what safe staffing's about. And we need to understand that.
So can I just say that this work that's been done in terms of delivering care and all of the work around the e-rostering, the combined staffing method, the training of staff, the production of an annual report, that hasn't been done before in this way. This is the sort of framework that they set out in Scotland haven't come from there, in terms of having those standards in and working. So the framework will actually provide the legislation around that, but there needs to be good guidance that comes with that actually sets all of this out. Now, we've done it for nursing and midwifery through delivering care, but actually this is wider than just nursing and midwifery in terms of the legislation, so that guidance, as in Scotland, would need to include the other professional groups as well.
I mean, you just picked up on an issue that I was going to talk about. Midwifery. So very little of the Renfrew report has actually been enacted. It talks about a service under stress. Daisy Hill isn't in my constituency, but I live in a part of the constituency where it is regularly used by my constituents. And last weekend, in an emergency, its unit, Obs and Gynae, had to close. And everybody was shuffled down the road to Craigavon. And I'm told that that's because one doctor, junior doctor, wasn't available to work. It's a threadbare service if that's what we're relying on, and if we are at a situation where that is the problem. Am I correct in that?
I think in terms of sustainability of services, and I'm not over the detail of the Daisy Hill episode at this weekend, but I think in terms of rota sustainability, having come from maternity services background, that can happen. And the safe thing to do is to redirect the take for that period of time. But I do think, and I know through the maternity programme board, that the whole sustainability of the workforce around maternity services will need looked at fully.
Okay, and can I just ask as a last question? Sorry, I feel as if I've been negative. I'm not negative towards the purpose and intention of the bill at all, but I'm kind of tired, like a lot of people, of hearing of good intentions without a lot of detail and processes that go on and on and on forever. We have now had the Adult Protection Bill, and we've been told that while we're going to legislate for this, I'm happy to do that. I've done a considerable amount of work in understanding the bill, and this committee has, in trying to actually improve the bill. But we've also been told that we can only partially implement it as and when. So what would the position be of a safe staffing bill in terms of both finance and people?
In terms of
Well, finance,
having
we've
the
been
finance
told
in place
that, for example, the Adult Protection Bill, we can't implement it all. We'll only implement bits of it as and when we can. We saw when we looked at the Mental Capacity Act that only one part of it, the part pertaining to the deprivation of liberty, has been enacted, but the part that actually advocates for patients hasn't been enacted. So how realistic are we going to have a safe staffing bill that will have both finance and the people to actually support that safe staffing?
So I think that's why we have been working closely with colleagues to try and prepare for implementation. And I think there will be investment needed in terms of trust at operational level to undertake the appropriate levels of workforce planning that we've talked about, and the reporting. Similarly at a regional level, and indeed probably at the department as well. We don't know what that is yet. As we work through the legislation, that will become clearer. But the ambition then would be that we would have that investment in place for, if the bill progresses, for the beginning of the implementation phase of the bill, I suppose.
So normally when we get a bill, a legislation here for the start of scrutiny, we'll get an explanatory memorandum, but we'll also get a financial memorandum. Yeah. Are you telling us we won't get that at the initial stage of the bill?
No, I think
We will.
whatever's normal, we will be providing. Yeah.
Will that be a best guess? What will that be?
Well, I think anything at this stage is always an estimate, but it'll be a robust estimate of what the likely impact will be in terms of cost. Because there will be a need for investment, as I say, in terms of the people to underdo the work that we're putting on.
And to work at kind of professional level, certainly in terms of our next stage is, that is very much about assessing the gap and then looking at an implementation plan that we will absolutely have to cost. To go back to an earlier point, just within this guidance, we have looked at complexity and we have divided cases into sort of complex, moderate, minor, and we are trying to allow for a sort of fairly balanced caseload within that. We have had problems with our, recent and still current staffing difficulties, that perhaps we have had teams where they've been all band 5 assessed during employment social workers, and that's clearly not where we want to be, and that's certainly something that we're trying to address as well. One of the other bits of work that accompanies this is about team composition. I'd spoken earlier about, this is one part of a wider package of workforce measures. So we have work ongoing at the minute to say, well, what should a team in Gateway Child Protection look like? How many senior practitioners should it have? How many assessed year employment? We've also made recommendations particularly for those people early in career, either in their assessed year in employment or even the 1 to 2 years after that, about moderating the caseload in a way that recognises the stage of their career that they're at, and sort of what skills and experience they would have at that point as well. So that is included.
If I may just, if Rodney might say.
Okay. Yeah, if I could just come in on a few of those points. What this bill will do is place workforce planning on a statutory footing. Okay, so we currently have 3 elements of workforce planning. There's the operational workforce planning, which is the day-to-day on the ground by the health and social care trusts and organisations, and then what we see is that middle layer, which is that regional oversight of that operational workforce planning by our commissioning organisations. Above that, we have our strategic workforce planning, which is that 5 to 10 year view of how many staff do we need to train our future talent pipelines. Currently, for example, that organisational workforce planning is being undertaken. There's no consistency necessarily across trusts or across the region. This bill will be mandating to drive that consistency, so that there will be a consistent approach to that operational workforce planning across all specialties and across all services, which will tell us how many staff we need, and that will be driven by the work that Anya and Maria have just discussed, and that will give us a better, more robust, consistent estimate of that and how many staff we have. That then drives into that sort of regional view of what is our supply versus what is our demand, and how do we best utilise ours, how do we make the most effective use of our staff across the HSE. So you're absolutely right in saying we've talked about workforce planning for a long time. This bill will hopefully drive those improvements in both robustness and consistency, which is necessary to sort of feed all elements of the workforce planning. We will then be able to identify the areas of particular stress across the region. We'll be able to look at ways we can utilise our staff more effectively. Do we need to have specific initiatives for recruitment and retention and so forth? And all of this is underpinned and supported by the workforce strategy, which we're undertaking. And for example, we're currently in the throes of developing a retention framework for our employers to look at ways in which we are currently out engaging with staff, and we've had thousands of responses just this week telling us what are the factors that would make you want to remain or leave the HSE. That will all help us to address those gaps that you talked about earlier, but it's placing that requirement and putting it on a statutory footing across the piece for all organisations to be workforce planning consistently will be one of the main tenets of this, that will drive that information and that intelligence that will help us then to plan services in a more effective way.
So it will be more than a high-level set of instructions to trusts to do what they should be doing now, hopefully.
So
I'll stop there.
the process,
Sorry.
and the requirement will be for workforce plans to be produced, and that will give us then that regionally consistent view in which we can then assess how many staff do we have, how many staff do we need, and how do we go about then bridging those gaps.
Thank you. I'm conscious that we might be getting into the actual details of the
Yeah, and
legislation.
you haven't seen the
No,
legislation yet?
Yeah, so
Neither have we.
Linda.
I'd be glad to know. I'm not going to ask anybody to get into the detail of the legislation, but I do look forward to seeing the detail of the legislation, because just to pick up on the point around the trusts and what, as Diana's just said, you would like to think they're already doing, but I think that there is also a piece of work around how well the trusts, the departments and SPPG work together, because nobody can do this in isolation. So if it's a case of we're going to ask the trusts what they're doing, what they need and how they're going to get it, but we're not going to help them, that's not going to work. So I'm just saying, that'll all be fleshed out in terms of the bill, I certainly hope, and if it's not, then we are going to have problems. But just in terms of the briefing refers to workforce planning, taking account of local contexts, and it will not come as any surprise to you, being a representative from Mid Ulster, that my particular concern when we talk about local context would be the rural element, and obviously you have a greater challenge in terms of recruiting and retaining staff in rural areas. So I just want to make sure that there are things within this bill that will support those areas. Now, I'm very lucky in one part of my constituency in that we're very close to a number of hospitals, particularly Craigavon, but in the Northern Trust and everything in the middle, and particularly those in the middle, and I think about like Pomroy, Kildress, The Rock, those kind of areas, they really are very far away from any service. So I just want to make sure that this is going to have protections within it in terms of the rural communities. So if you can give me some reassurance around that, I would really appreciate it.
Certainly, I expect the planning tools and the tools that Maria and Anya have described, we'd recognise the local circumstances, say whether that be rurality or distance or whatever the
So as part of that workforce planning process, because it is the process, you would factor things in like rurality, travel distance, potential use of technology as opposed to bringing people places. So there's lots of different things that you would factor in terms of context, and that would need to be very clearly set out in the guidance.
Look, I think the other questions that I had have actually been covered. I would just add to what Diana said, bring them with you. This is something that the Royal Colleges want. It's something that they're keen to be part of. So, and if they're not being responsive, then if you can show that you've done everything you can to engage them, then that's a different thing. But it has to be more than just saying the consultation went out. They're not like the rest of the public there whenever it comes to a consultation on something like this. They need to be part of it. They need to be fully engaged. So just think that's important. And that's a comment you don't need to respond to. It's just a thank you, Chair.
Thanks, Linda. Danny.
Thank you, Chair. Thanks very much for coming today, and thanks for your presentation. This is long awaited, so I absolutely welcome it. I know lots of staff are very, very keen to see this. I come from a nursing background, so I'm going to declare an interest here, working as a nurse within the health service. I read recently that there are, as of the 31st of March, there are 1,875 nursing vacancies across Northern Ireland. These are spread across, wards across all our hospitals, and that is felt. And certainly I know a lot of staff do feel overworked, overstretched, overburdened, and that stress and strain does have a physical and mental impact on them, and we talked about retention earlier. So how will this improve the stress and the strain that our staff are feeling at the minute because of that burden that's put on them?
So I think, I suppose, if I just look at it from my perspective, it's very hard to have visibility of the workforce data on a day-to-day basis, Danny, that you're talking about. By actually developing the roster system and producing real-time data for that will feed into workforce plans, not just on a not just on an annual basis, but on a regular basis, and will be seen as part of the safety culture within the trusts. And that visibility is really, really important to help staff, one, realise that they're being listened to and heard, and that people actually understand the pressures that they are working under. The other aspect of it is to actually identify, so within all of the establishments, to make sure that we have the right establishments for each of the areas that we're working in. It's very hard at the moment to actually be able to differentiate that. And so when I look at the utilisation of agency, I'm not able to say currently that actually what that agency is being used for. Is it being used for additional beds in the ward? Is it being used for corridor beds? Is it being used because we haven't factored in the predicted absence allowance when people have been doing no roster duty? So there are many factors of the unknown at the moment. So it feels very overwhelming. To have that knowledge for staff and for team leaders is really, really powerful in actually articulating the pressures that they're feeling, and not just sounding like they're under pressure. That gives them really hard evidence of what's happening. It also actually they will be able to demonstrate acuity and complexity within the wards as well. And it will allow us to do benchmarking across Northern Ireland, which I think is really important. So a 30-bedded respiratory ward in the Western Trust, does that have a similar staffing to a 30-bed respiratory ward in Belfast Trust? Because there shouldn't be that much variation in the difference. So it will give us much better information for them to work for it. It puts the power back into their hands in terms of both escalation of concerns, but also the articulation of that concerns and data. So it can't be argued with. And that is a good place for staff to be in.
Absolutely, and that sounds as if it would be a powerful
Yeah.
change, and
Yeah.
I certainly hope it is.
Yeah. The other thing, just I say, is that in delivering care, the accountability framework is from the ward to the board. So that's very clearly part of the new quality and safety measures. Because if your workforce is challenged, then inevitably the safety of your care can also be challenged. So it's really important that we get this right.
And nursing is a safety critical profession.
Absolutely.
If we don't have enough
Absolutely.
nurses, patient safety then is compromised, could be compromised. I was really glad to hear you mention, although we aren't having hard figures in the legislation, you mentioned the use of tools for measuring it, and standardised evidence-based tools are very, very important. I know there are ones that are regularly used. The BEST tool is used in A&E. Safer Nurses Care tool is used in acute wards. Are these the tools you're talking about? And
Yes.
if so, will they be mentioned in legislation, and will the need for them be mentioned in legislation?
Yes, so they will be mentioned in legislation as and if there is an evidence-based workforce tool for that area. I wouldn't be specific because those tools will change and emerge over time.
Okay.
So we've also been having conversations, Danny, with Scotland, who have agreed that we can also utilise their tools if necessary. Northern Ireland is probably too small to be developing its own evidence-based tools, so I think having tools that we can utilise, we've gone with the Imperial tools at the moment, so we have funded them for 2 years. They will be implemented in June. The training is ongoing, and then they will run twice a year. So this year, at the end of this year, we will have the first run of that, and then by the following year, I would expect to have that sort of trend over time with that, and then the decision will be made if those are the right tools for Northern Ireland. And the RCN are very supportive of that work. But it is a test at this time because there are lots of different tools, but these are the ones that we know have been evidence-based.
Yeah. Phil, you mentioned just in your opening remarks about co-design, and that this has been co-designed with the unions and the trade unions in particular, and Diane mentioned the Royal College of Emergency Medicine and the BMA both haven't been involved. I think Linda picked up on that as well, that these are key stakeholders. So, again, quite surprised that they haven't been involved, they haven't been engaged with. If we were to ask the trade unions about co-design, would they tell me that they feel that this is co-designed?
I think if you spoke to Rita Devlin, I think she would. I would hope she would say it's been.
I think she would.
I think she would.
We will be asking.
And I think, in fairness,
she works very closely with them.
and I think if we think back to the very start of what I said, this started off just as a a piece of legislation for the nursing profession. So that Rita was in very much from the beginning of that. RCN were in from the beginning of that. So
You're quite confident there, but again, I would agree with other people to please engage with all of those stakeholders.
yeah,
You know, their input would be invaluable into this legislation.
certainly I think, you know, look, we're happy to do that. I think as Andrew outlined, BMA did respond to the consultation. They didn't respond to an invitation to talk about it, but we'll follow that up and we can do that.
Okay. You've mentioned reports there. What enforcement mechanism will exist if organisations fail to meet these requirements? What's the enforcement? What's the teeth to this?
Do you want to take that one?
It's all about accountability, really. So obviously, and transparency. So when the reports come in, we're not talking about, obviously, in very extreme circumstances, such as Daisy Hill, they made the decision to close the ward. We don't want that. We're setting the tools to improve the service. Because the reports are being produced and we're recommending a full report and interim-based reporting, there's accountability there. So there has to be transparency as well. So I suppose it's about, if things are going wrong, it's out there for everyone to see. So and that's where we then have to have, as we've mentioned, the different action plans with all different levels to see where it has fallen down, where it can be improved upon, and that's a constant improvement cycle. So it's always going to be, you know, we're always going to be improving. It's not once we reach a steady state, we're not going to be saying, well, that's us. We're going to have to keep improving just to make sure that we are staying ahead of it if we can. The legislation, we with regards, because obviously we're dealing with public health, we can't mention sort of financial, any kind of the standard punishments, if you like, you know, whether it be financial or it be closing, that's going to be no use to anybody. So we're hoping we're not, this isn't going to fix every problem. We're aware of that. Whenever humans are involved, there's always going to be some kind of a risk, but it's who's having the accountability over that risk and what are they doing to address it, because it is going to be out there. It's going to be transparent, you know, for everybody to see.
And if they don't address it, if these places are running short-staffed, well, what's, you know, where is the accountability and what will happen?
Well, it's going to be going right up. I mean, it's not going to be just based at trust level. I mean, the reports will come sort of through, if you like, the process will be trust to SPPG or PHA to the department to even higher if necessary. So it can go right up. But again, with regards to again, it's punishment level. We're not wanting to close hospitals. We're not wanting to do that. But it's again being accountable to where we've gone wrong and trying to make that right or better to stop it from.
This should all be based on patient outcomes, and we hope this will improve patient outcomes. That's the point of doing this. How will the department measure the impact of this legislation on patient outcomes?
I suppose if you just go back to the common staffing method, that's a triangulated approach. So you're not just looking at workforce and workforce numbers. You're looking at workforce numbers, quality of care, you know, complaints, your safety indicators as well, and you're actually triangulating that all of that data. So if, for example, I was running with low workforce and my complaints were going up and my incidents were going up or my quality was changing, then you're seeing that in the round rather than them all being seen as separate aspects of how we deliver services. Danny, I think in terms of the process around having a statutory framework around safe staffing, it gives very clear evidence and transparency to what is actually happening, and it needs to be supported by good data across all of that common staffing method to ensure. Now, that doesn't mean you can get nurses or midwives immediately because there's a training and there's a supply line to that. There's a turnover rate. You know yourself that you can have high sickness levels or maternity leave at any time, but you'll see by actually having this process much clearer and better than how you're using supplementary staffing like bank or agency against those trends, which gives you much better and detailed information, which we actually do not have in Northern Ireland at this moment in time.
Just with that as well, I've heard from staff that are saying that, you know, they're being pushed towards bank shifts, and you'll know when you do a bank shift you get paid your basic rate when they've worked their full complement of hours, so 37.5 hours, and they're being asked to do extra shifts and pushed to do them on bank as opposed to overtime. Do you feel that's fair on those staff? Is it something you're aware of? Or?
Yes, I am aware of it. I do think that if the staff, there's a variation there. Some staff will have worked full time. We've got a big percentage of staff that don't work full time, as you know, so those additional hours would be paid at their grade as if they were working full time. I think to do that in the bank is the right thing to do. I think we have a accountability to the public in terms of how we utilise our funds across the service, but in terms of the arrangements for overtime or pay use, that is goes in area of negotiation. But
part of
it would be attractive to those staff if they were more attractive to those staff if they were paid at an overtime rate when they were doing overtime, rather than being pushed and directed.
I think for that is something that needs to be negotiated through that process. But I hear what you're saying.
I suspect something that you're hearing is probably you'll be aware of the work that's ongoing in terms of agency reduction, and there is we're trying to push people from agency to bank, and that would certainly help. But certainly, when we're thinking about if a shift is unfilled and needs to be filled, not by a substantive member of staff, it could be for sickness or whatever reason, the options are overtime, the options are bank, and the options are the last resort should be agency, and so. But it'll be the trust and the ward managers who will be making those decisions as to what people should be.
Certainly, if people are doing more than their 37.5 hours a week, it should be reflected.
I would expect that they should, for any hours above that, their full-time hours should certainly be paid at overtime rates.
And I think that needs to be looked at on that basis. Why, what are you using the supplementary staffing for, Danny? But also, is somebody full-time? Is somebody part-time? Is it additional hours that somebody wants to do within their 48 hours? So I think it's very hard to have it completely. There needs to be a range within that people use. But we do need to move away from agency utilisation in Northern Ireland. We had a huge expenditure on that. And that's why I think this is really important in terms of understanding what we're using agency for.
When you have higher rates at agency and lower rates at bank, it encourages people to go to the agency.
Yeah.
Of course it does. So I'm really looking forward to seeing this legislation coming forward. I share the concerns that we don't have a lot of time to scrutinise this. If we get it in September, that gives us 6 months effectively, which and there will be gaps in there as well. So at a time when we'll otherwise also be looking at other pieces of legislation, so it will be very intense. But I'm very much looking forward to this. Thank you.
Just on that last point, I appreciate that, and we have met with Keith and his colleagues to try and see how we can better work together when the legislation's with you and you're going through your phase of the legislation. So we'll try and work as best we can with the clerks and yourselves to progress it.
Alan Chambers.
Thanks, Chair. Chair, I have a couple of questions, so I'll ask them all at once and the panel can reply to them all at once if that suits. I appreciate that there's a regional overview of all this, and there's frameworks and there's benchmarking, which will be able to be deployed across all of our S settings, but there'll always be an individual setting that sort of doesn't fit into a pigeonhole. So in a case like that where the trust have to decide what, in their opinion, is a safe staffing level. Is there a danger that judgment could be clouded by budgetary concerns or lack of budget, and that would maybe cloud their judgment? And also, if staff in any setting feel that they have concerns that maybe the safe levels have been cut just a little bit too fine, is there a mechanism within the legislation where staff can ask the department maybe to arbitrate or to look at just what the level has been set at by the trust? And the chair talked earlier about the, a shortfall, say a ward in the Western Trust, a psychiatric ward needing 10 nurses, but there's only 5. What would happen? And you said, well, you would encourage them to recruit and blah, blah, blah. And then Danny there just asked the question about, well, at the end of all that, how long does that go on, and what's the enforcement? And if I hear you right, you're saying you're reluctant to go down that road, and you'll escalate it up various levels. But if something horrendously went wrong during that period of, while you're elevating it and looking at it and encouraging, something goes horribly wrong, where does the buck stop? So, thank you.
Okay, there's a few questions there. So, I think the first one is probably for difficult settings and how it's using professional judgment.
Yes.
So maybe invite Maria or Anya to say something about that.
Yeah, usually for difficult settings, or if there isn't an evidence-based tool that could be applied to that staffing level, then that would be about professional judgment based on the number of beds, the staffing, the complexity of the patients, or if it was in a community setting, the similar approach. In the community setting, it may be that you have caseloads of a certain number, or there's a certain number of nurses to a population group, maybe 1 to 20, to 10,000, which I think is for some areas. So you would apply that methodology to that. So there has to be there has to be a level of local context within that takes in that into account. And that is built into this process in terms of the common staffing method as well, which is it's a process that people can work through, but it's a consistent process that would now be applied to every area every time in Northern Ireland, which is the right thing to do. Now, there will be variation initially until people become more familiar with the utilisation of that, and there needs to be training around that, which we're starting, but that's going to take a while to roll out and actually ensure that because you want everybody who's doing anything to do with workforce planning to be trained in that process, because it is a process that requires a level of skill and knowledge to it. So that's really important.
But I'm asking, is there a mechanism if a member of staff, I suppose you would call them a whistleblower maybe at some point, if they felt that the level of staffing wasn't sufficient and it was causing a risk to patients, is there a mechanism there, and who would arbitrate on that?
Maybe if in terms of the legislation, Andrea,
yes.
do you
In
want
terms
to
of
say?
the legislation, we are proposing that there are visible risk escalation processes. When we talk about risk escalation, we're not talking about high level, we're talking about every level, so that they're transparent. So everybody should know, if this is wrong at my level, I go here. If that doesn't happen, I go here. And that way, I suppose, if it's not being followed with these transparent processes, that can then certainly go to yourselves as a constituent to say this isn't being processed, this isn't being followed, because it is in the legislation, the risk escalation processes that should be there.
Is there a danger, but when you talk about if a whistleblower goes to somebody and it goes to another level and goes to another, is there a danger that it can get lost? And that people would be discouraged from whistleblowing because they feel, what's the point? Because it's not getting acted on. They don't see what's going on behind the scenes, and
So in the Scottish legislation, one of the key things was, in terms of escalation, was one, that there are documents recorded so that there's an evidence-based trail of escalations, which is very important, and there are systems that we can utilise to do that across the trust. The other bit around the escalations is that for sometimes a staff member might think, look, actually this feels very busy to me, but actually a more experienced person might say, well, actually that's safe, or that's not unsafe, because actually the complexity is not, and you have a fair complement of staff. So there has to be a bit of that within that process as well. Charge nurses are very skilled at this, and they do it every single day but it's also then the demand for those services, and are we seeing an increase in demand for services, and how do we respond to that? So I think the big thing around the escalations is that, one, they're documented, they're captured, they're monitored, and they're part of the workforce plan. So your annual workforce plan, says how many escalations you've had in a year as well as everything else. So that is a really important part that needs to be built into any guidance and around this.
And a big one there was that just about if something did go wrong during that vacuum when you're trying to work the staff up and get it up to levels, where does the buck stop?
I think the levels of accountability need to be for operational day-to-day is at the board, and then the escalation from the board into SPPG, the commissioners, and then into the department.
If I could maybe come in on some of that as well. So just you had talked about a concern that safer staffing might be decided with maybe a budgetary implication, and I suppose I would hope that we would avoid that, because we have recommended caseload ranges. So although there's professional judgment within them, there is a standard set, and this is the first time we've had standard set for social work as well. So it's a significant move, and welcomed by the profession, that there is a standard, that it gives the guidance to work to. We also in the guidance have built in escalation, and also talked about the importance of contingency planning. Where a team isn't at the staff requirements, and we also see a lot of the sort of discussion about maybe a staff member is feeling under particular pressure, or known vacancies within the system as well. Again, we would rely heavily on the professional supervision process to allow staff to air those concerns. That would be very much part of what we have recommended about the things that need discussed about caseload and workload.
Thank you. Thanks, Chair.
Thank you. Paul?
Thanks, Chair. Phil, just help dispel my train of thought on this here. And I was listening to you intently, and you'd said that the way this works is that locums are brought in to cover. I assume that there is a heavy onus in this legislation on the trusts. That is correct.
There will be requirements in the legislation for
These are
things that the trusts are expected to do, things that the commissioners are expected to do, and things that the department is expected to do.
And these are trusts that are already being expected to deliver millions upon millions in savings. And this is where my mind is taking me to, that when you were talking about locum cover, that ultimately the outcome of this legislation, and I hope I'm wrong in this here, my way down a different track, that ultimately the end game in this will be that in order to fix this, more money will be spent on bringing in locums. Ultimately that could be the outcome in this. At a time in which we're already, what is the figures we were given, $500 million spent on locums in the past 3 years?
Our expectation would be that the outcome will be not that we would be employing locums, but we'd be employing substantive staff. So it would be, as I say, you identify how many people you need in a particular service, you then identify how many people you have in that particular service, and then the actions, the requirement will be then detail the actions that you are taking to address that gap. And we would expect, in most cases, that will be actions to increase the numbers of substantive staff delivering service.
Yeah. But it needs to be focused on your population health needs. So just going back to Philip's conversation around psychiatrists, for example, and I'm not a psychiatrist, so I won't come for them, but if our population health needs are changing in terms of, for example, more people requiring geropsychiatric services, then that's the type of workforce that we need. But also, how can psychologists contribute to that? How can the wider healthcare team, occupational therapists, nurses, how can you redesign your services so that you're not just asking for the same workforce as you've always had that may have been suitable 20 years ago, but actually could be delivered in a different way today. And that is part of how we need to do that effective workforce planning, so that we can respond and ensure sustainability of services going forward whilst maintaining good outcomes for people.
I think we would also hope that by having safer staffing and by having guidance and standards in place, that eventually that would actually lead to staff feeling more supported, stable, that they've more of a more stability in what they're doing, and that would reduce sick leave and pressure, which in turn then would reduce the need for any form of temporary staffing as well.
Okay, we look forward to September. Thanks, Jim.
Thank you very much.
Thank you.
And don't be delaying in September. Thank you very much.
Thank you.
Okay, members. So we are now on item number 8, oral briefing from the department on the June monitoring and budget priorities.
Sure, you have to excuse me, I have to leave the meeting.
Report.
Just about. I can't go to the toilet then.
You can, we just can't
So
make
we're
any
going to make a
decisions.
decision.
Yeah.
Sad about Tom.
Hmm?
Sad about Tom. Sad about Tom.
Oh, big shock last night. See, he was at a meeting yesterday.
I had a meeting yesterday, scheduled with him yesterday, with Tom Frolan. Got a call first thing in the morning
It's a big
to
shock.
say, desperate.
Okay, so we will welcome in our next delegation from the department. So can I welcome David Keenan, Interim Finance Director, Danielle Mallon, Head of Financial Management, Paul Montgomery, Investment Director, and Catherine Fitzpatrick, Head of Capital Resources Unit. Thank you. You're all very welcome. So members, papers are page 7 of the main pack. I asked yourselves just any opening remarks you may have before we go straight to questions.
Okay. Thank you, Chair. I'll start by making a few remarks, providing an update on how we outturned on our 25-26 resource budget, and then secondly on our 26-27 financial plan in the absence of an agreed budget by the Executive. And then I'll hand over to Paul to cover the capital position. Firstly, we'll start off 25-26 outturn. When I briefed the committee in February, I advised that despite delivering significant savings this year, it would remain a challenge to break even. The department have delivered some 325 million of savings and have received one-off support of non-recurrent funding of some 300 million, which included our share of the reserve claim of some 185.4 million. The combination of these factors has meant that the department have outturned with an underspend in DEL resource of some 1.3 million. Given the size of the funding gap we started the year with, this represented a positive outcome. We'll move on now to the 26-27 financial plan. In the absence of an agreed budget, DOF has issued contingency plan envelopes as a necessary interim measure to maintain the delivery of essential public services while ensuring spending remains within legal and financial control limits. These contingency plan envelopes do not constitute a formal budget settlement, rather they reflect a prudent estimate of the level of funding that could be reasonably be expected to inform a future budget position for Executive for consideration. As a department, we are required to manage our spending within these limits, ensuring it's all affordable and justified. For health, we believe it's reasonable to assume that we will receive the level of funding included in version 2 of the Finance Minister's multi-year budget executive paper, which was issued on the 2nd of April. This means we've assumed for financial planning purposes that we'll receive an additional 171 million general allocation on top of our baseline and 165 million ring fence for waiting list funding. However, you should note we require the certainty of the waiting list funding being allocated to our baseline recurrently, as it's essential to cover inescapable pressures for red flag and time critical patients and to build capacity within the system. We've also had confirmation of some 22 million of transformation funding to continue the further rollout of the multidisciplinary teams and for 2 new transformation projects, Together for Families and e-pharmacy. However, based on these funding assumptions, we're faced with a funding gap of some 0.8 billion, which is needed to cover 25-26 pay requirements and meet our Minister's priorities in terms of 26-27 pay, real living wage and other inescapable pressures. To address this funding gap, the Department has set targets to deliver some 6% savings for ourselves internally and across all our ALBs. This process is ongoing, but it should be noted that even if we deliver these savings in full, it would only halve our funding gap and would still leave a funding deficit of some 0.4 billion. We've been consistent in our position throughout the financial planning process, and that without additional financial support, we will not be able to balance in a single year. Our financial plan has always been to seek agreement on a recovery plan over the 3-year budget period, which will allow managed delivery, though it would still be exceptionally challenging and not without risk. We will continue to take all possible steps to progress our plans and maintain service delivery as effectively as we can in the absence of a confirmed budget, maximising the use of available resources and driving efficiencies wherever possible. However, the lack of funding certainty may limit what can be achieved. I'll now hand you over to Paul to cover the capital position.
Okay, thanks, David. In the absence of an agreed budget, the primary focus in managing the Department of Health capital budget this year has been in respect of the inescapable pressures facing the department. The draft budget proposals published by the Finance Minister in January, if they had been agreed, would have allowed the department to meet the inescapable pressures that had previously been identified. In addition, it was expected most of the partially committed projects for the department could commence over the budget period, albeit with some delay. The proposed capital budget allocation to DOH for 26-27 in the draft budget document was 463 million, which was later reduced to 430 million to reflect the revised investment profile for the new Children's Hospital. In advance of capital budget being confirmed for DOH and to ensure continued investment in the HSA infrastructure, the Minister has agreed indicative allocations of £364 million in respect of the DOH inescapable pressures only. This includes capital funding for the new Children's Hospital, the Lisnaskea Health and Care Centre and digital initiatives, including Microsoft software licences. In addition, a small amount of funding has also been allocated for the development of plans for the perinatal mental health mother and baby unit. Looking to future years, a 10-year capital investment plan for the department is to be developed to present the projects and programmes expected to be funded from the DOH capital budget for the years 26-27 to 35-36, subject to each project receiving business case approval and confirmed funding. The intention had been to take forward the development of a plan following the agreement of a budget by the Executive, as this would provide a confirmed position in respect of the funding available for a large part of the decade. In the absence of an executive agreement to a budget, we continue to review what scope there is to provide additional clarity to ALBs and business areas on the future capital funding allocations. Okay, thank you. Happy to take questions.
Okay, thank you. So, I mean, in terms of what has changed since you were last here and now probably not a lot, only slightly worse, and we are now the very real uncertainty about whether they can get an agreed budget. So in terms of the impact of that, I'd be interested to know. I actually was at an engagement last night and there was representatives from the Northern Trust, so they were saying about the 50 million that they have now been cut. I presume that's the case across all trusts. So I mean, is there what has been flagged up as a warning in terms of potential service cuts from A, the trust, and B, the department, and the impact of no agreed budget?
Well, at the minute, as I mentioned in the sort of opening remarks there, we have set targets for them all. At the minute, the trusts are getting on what we would call phase 1 of the targets. So there was a lot of stuff there in relation to sort of cost reductions, not there too, like sort of agency reduction, workforce and vacancy control, additional savings through the MORE programme, the MORE pharmacy programme. They're progressing those savings at the minute. the Minister has said at the minute he does not want any savings progress that may cause patient harm. So
There's a difference between patient harm and good service provision, so I'm kind of keen to explore the gap between those two scenarios.
Well, at the minute, basically, trusts are now apart from those for the phase one, what I would call phase one of the savings, trusts are now refining their basically savings plans to see what actually can be delivered that won't cause patient harm. In terms of impact on services and that, I mean, obviously they're going to have to look at in terms of consider if there's going to need to be a consultation and that there too as well on that. So again, that process is ongoing, and I think I sort of want to make clear too, this is a plan at the minute, which will likely evolve as we move through the year, and you'll see in the paper there, for instance, there were savings applied to trust there of some 387 million. We know at the minute that could only be achieved, and that there, which would have quite severe service impacts, and so that figure will now come down. And that too, that basically that savings target is not achievable at the minute.
Okay, and then see in terms of pay for staff, because we can't have a functioning health service without staff, and it's a recurrent issue in this committee, no less than today. So just explain exactly what the Minister's plan is, should he get the budget that is in the draft, and you seem to be indicating you expect to get that at least.
Yeah.
So in terms of that, what is the Minister's intention with regard to pay for staff?
At the minute, based on that budget allocation, pay is unaffordable. So it would need to be a ministerial direction in order to basically implement the pay award. I mean, to fund that pay award, you would have to stop you would get into the stage you'd be stopping services, which would cause patient harm.
Okay, so I'm talking about right across the pay, including, as you mentioned, the living minimum wage.
Yeah.
You're essentially saying with the current budget, the Minister can't do any of that.
He would have to issue a ministerial direction.
Or could he do that and make other decisions given his budget? I mean, that's obviously an option.
Looking at where we are at the minute, it would be very challenging, because from what we're seeing at the minute. In the phase one savings at the minute, there's about 204 million of savings there from trusts, but that also includes some 54 million of savings that they said was non-recurrent last year. So the impact on us, how we're looking at that, is basically it'd be like 150 off our sort of funding gap, and that so in terms of, it's not as easy as you sort of said there, in terms of could he make this, it'd be incredibly difficult, and it's likely to cause patient harm to make a decision to cover that 26-27 pay award. Because I think what you also have to bear in mind is we weren't funded for 26-27 currently. We only got funded for that for last year, for that. We only got partly funded for that year. The balance of the pay for 25-26 was funded through that reserve claim. So we're carrying the recurrent nature of that, and that has to be met. Out of your budget, the pay that was protracted last year. Unfortunately, it went right to the end. Not there to honour that this year, and that's a commitment we can't get out of.
To honour next year's pay awards and make sure that our social care workers get the minimum living wage. We'd love to see them getting much beyond that. To be perfectly honest about it, how much extra does the department need?
In terms of just pure the pay award and the real living wage, you're probably talking about 280 million.
Okay, okay, that's interesting. Danny?
Thank you, Chair. A lot of concerning answers there. Very, very concerned to hear, some cuts may result in patient harm. And I appreciate your minister.
The minister's already ruled out, and I think that's the direction he's given. Is that basically no savings can proceed. It will have patient harm.
Which savings proposals have been ruled out then?
Well,
the ones that will cause harm. Which are they?
It actually was basically the savings proposals were presented to him, and it wasn't a case that the minister went down and said, I'm not doing this, this and this. He basically said to the trust, go away and take out the trust, you take out anything that's going to cause harm to patients. So we can't, it's not for us in the department at the minute that we could actually pick those out and identify which ones, but so that the trust at the minute, that's what I was saying, they are refining those that we're calling like phase 2 of the savings measures.
Okay, so the trusts are removing the cuts that will cause harm out of the 6% savings that they have been told to meet this year, 6% next year, then 3% the third year.
So we always were looking at this as like a 3-year recovery. So the plan was, like, given the size of the gap, there was a belief that the maximum we could deliver this year was a 6% reduction. I think there is an understanding is that we need to get the HSE cost base down, and
what's the highest percentage that has been cut before in 1 year, saved before in 1 year?
Actually, I'm not off the top of my head. Probably somewhere around about 3%.
We've never come near.
We've never got to 6. No, 3. It could be maybe between 3 and 4. Might be the highest. So 6 was ambitious, at least. So the original plan was to aim for a 3-year recovery period, 6% in the first year, 3% in the second year, and 3% in the third year. Where we are now, it's looking like more like 4, 4, and 4.
So it looks as if the savings targets are going to be missed. How is the department going to manage that shortfall?
At the minute, we can't.
We can't pay uplifts. We're not going to meet our savings targets. We're going to have a massive overhead deficit at the minute. And you've already said, the amount that we need in order to be back on track. Can I just ask, phase 1, as you've said, that's where we are now. That's where the trusts are trying to identify cuts that won't cause harm effectively.
Yeah, so they're proceeding with phase 1.
Yep. You mentioned vacancy control there. Given what we've heard, we already know there's vacancies right across the trust in some areas up to 75%. Patient care clearly is suffering there. What do you mean by vacancy control?
About getting the right people in the right place, and not there too. So, basically evaluating each vacancy, not there too, before it's filled.
Does it mean not recruiting to vacancies in order to save money?
Certain vacancies it would mean that basically you wouldn't be recruiting to.
You'd be putting extra stress on the staff who are still there doing the jobs. You'd be putting patient care effectively at risk here.
Well, another thing, possibly some of those people are already filled by agency staff at the minute. Because to maintain service delivery, if those gaps are there, they're probably being filled by an agency person at the minute too. It's basically introducing a prioritisation into your recruitment.
Can we say what capital projects? I know you'd mentioned a couple of ones there that are going ahead, and certainly glad to hear the Children's is still going ahead, Lisnaskea Health Centre, and the small amount for the mother and baby unit. What capital projects are most at risk? Have you identified?
Well, we're focusing on the projects that we're able to fund. So we're focusing on the projects that we've been able to fund.
So everything else is at risk at the minute then? Everything else that...
we have been able to fund the inescapable pressures, and if we got a budget, we would expect to be able to take forward some of the partially committed projects, albeit with some delay. Even if we got a budget, some of the projects would be with delay based on the draft budget proposals. There are, I think we've discussed previously about projects that have not been committed to previously. We would not be able to take those forward.
The likes of the mental health hospital at Antrim?
That would be a partially committed project that we would expect to be able to take forward across the budget period. Perhaps not in the timescales that have been put forward by the Northern Trust, but we could take them forward over the budget period if the draft budget or the budget was agreed.
Okay. Digital projects. What digital projects are most at risk? Is there any?
Well, we're spending 140 million on digital projects. So that is 40% of the capital budget. So we're significant. So
How much of that is Encompass?
Encompass is 15 million.
15 million?
15 million.
And is that recurrent £15 million a year?
No, the capital projects are not recurrent, so that's...
But is there a cost to Encompass every year? Is there a cost that will come back every year?
Well, for the duration of the programme.
Which is how long?
This will be... Apologies. Encompass will be going on until 2033-34.
2033-34.
Although it is much reduced spend, I have to say, going forward in future years. You know, we're 15 million this year, 6 million next year, 1 million, 8 million, 3 million, 4 million, 3 million.
A lot of millions.
But relative to the amount that's been spent to date on Encompass, it is there is an additional one of the pressures that we do face in terms of digital projects that we are not currently able to address is in respect of Encompass. I think it is £25 million in Encompass. An additional pressure has been identified this year.
What was it for?
Encompass. I don't. Because we don't have the funding to fund it at this stage. We haven't gone into the detail of what it actually involves or scrutinising it because there's no question.
On top of the 15 million
Yes.
for Encompass, there's another 25 million
Yes.
that is not being able to be funded. So is the 15 million inescapable?
15 million is inescapable, and it is because what I said was that we were able to fund the inescapable pressures that had been identified at the time of the budget.
Mm-hmm.
Subsequent to the budget, DHSC and I have identified a further pressure of £27 million this year
Due to Encompass.
due to Encompass.
It was not thought of before, or?
Well, I think costs are rising. Anybody who looks at the investment in AI, etc., you know, the costs will increase. There's also an issue about the scope of the project as it expands. I think they're looking to expand the scope of it, so all these pressures are being considered. But what we're saying to the likes of Encompass is that you need to look at your costs. You need to look at if there's an increased scope, do you need to increase the scope of it? Are there other projects that can be scaled back if Encompass is an inescapable pressure in order to release the funding for it? Are the costs you're talking about, are they, could they be lower? Could costs be lower? So we're asking, in the absence of a budget, until we get a confirmed budget position, we're asking, particularly the digital projects, to look at ways in which they can manage it within the 140 million that have already been allocated.
Very, very concerned to hear that there's another Encompass bill of 27 million that won't be met on top of the 15 that will. That's 42 million this year should have been spent on Encompass.
Well, once there's a budget agreed, and if the budget is agreed to the draft budget position that's been proposed, that has been set outside, our intention would be to fund that residual from the residual funding available, because because of the guidance from DOF, we've not been, and because of the uncertainty around the budget, we've not allocated the full amount that has been in the draft budget proposals.
Sounds as if there's more and more money going into Encompass than was ever envisaged. It's certainly something that it sounds very concerning to me.
I think it's still within the project, the overall. There was an awful lot of money that was supposed to go into the original business case. That was in the original business case. So obviously, if there is a significant increase in the Encompass projected spend, then it would need to be subject to business case addendum.
Okay, and just one last question. We talked about inescapable pressures, and we've mentioned the real living wage. Does the department consider the real living wage an inescapable pressure?
It's ministerial commitment at the minute.
Does that mean it's an inescapable pressure?
It still requires a decision. It's discretionary at the minute, but the minister has given a commitment that he wants to fund it. So that's why it's built in the plan.
Not an inescapable pressure. So it might not happen.
It may become an inescapable pressure.
It may become, but it might not happen.
The minister's given a commitment that he wants to fund it. So, I mean, it's likely there is a contract in the Western Trust that's going to be come to sort of awarding in the next, I think, number of months, At that stage, the real living wage will move, its potential to move to an inescapable pressure.
We're talking in a couple of months.
It may, yeah, but
May happen.
but the same. But I have to answer. It is a ministerial commitment. He wants to pay it.
We wanted to pay it previously and it didn't happen.
He did,
and we
but
promised it
he
previously and it didn't happen.
But at the high
So-
is getting viewed at the minute. It's being very much viewed very differently this year in terms of it will be wrapped up into our whole pay at the minute. Where because what happened was last year was basically a lot of the pay from the pay review bodies, a lot of that sort of work had started, sort of March, April time. Real living wage was going to come in much later. It ended up being two, both separate. In other words, anything that happens with pay will involve the real living wage.
The pay work might have started then, they didn't get it until October, November.
Yeah, but what I'm saying is that from us as a department, we are viewing them as basically one package at the minute. But there's potential
Not
that
an
the
inescapable pressure.
that the real living wage may become inescapable.
May become
It
inescapable.
may become inescapable, but at the minute it's a ministerial commitment, like the 26-27 pay.
A lot of mays there. But thank
Well, there's
you.
no funding.
Yeah, no, I absolutely get it.
Yeah.
Thank you.
Okay, Dan.
Thank you, Chair. I don't really want to go over the ground that we've covered. I think some of it is pretty bleak, to say the least.
Well, farmers are facing this. I don't think we're unique, in there too. I think it's bleak. I think it's bleak right across the whole block at the minute. From any discussions we have with other departments.
No, I don't think it's also, but it does actually mean that the push for transformation is, not just inevitable but imperative, because we are spending more per head of population on healthcare than any other part of the United Kingdom. That is correct, isn't it? So
Yeah.
it does mean we do need to get to a stage where we're spending money better.
Yeah, we are, but we have a relative need here of what is it? And the Fiscal Council says anywhere between 4% and 7% per head higher, and what was it that Treasury's country and regional analysis report says that last year we were at 6%. So we're within that range of need that the Fiscal Council have demonstrated that we need here. So it is correct to say we're higher, but it's based on relative need.
And
don't think
David,
we're higher than
I
Wales and Scotland.
wish you every Godspeed in your negotiations with Treasury on that issue. I'm not, I'm just saying I do think that most people looking at spend, if we're spending $500 million on locum over the last 3 years, that is an enormous amount of money that we could spend better.
Yeah.
And I know we will always have need for emergency cover. I get that. But I'm just saying that there is also the need to spend better. Can I ask a little bit about, just following on from Danny's questions about Encompass, do you have or can you set out for the Health Committee the total cost of Encompass from start to now? I don't ask you, I'm not asking you to do it now, I know it's fine, Paul, but
We have them next week.
we have them
It's
next
the last
week.
presentation we have.
Because
before
I
recess.
do think that is, because we seem to be talking about 7 million here and 2 million there and 25 million that we haven't accounted for. I think it's time we had a little bit of accountability from Encompass as to what we're actually doing and what we're delivering, because I talk to people about Encompass and then they say to me, but it's not really giving us that data. It's not really working on that level.
Again and again.
You hear this as well, yeah. And I do think we need a little bit of accountability from Encompass as to how that money is being spent, because you can't just. Paul rounded off the number of millions that we would need over any number of years. It's quite substantial. So that's just by the by as well. I think that's important. In terms of capital expenditure, we are going ahead with the Children's Hospital. That's right. That's good and proper. I have no issue with that. In terms of that expenditure, though, are we still within the funding envelope? And is the additional money that is being spent on redesigning the water system, in the Children's Hospital additional to the overall amount or within the spending envelope?
It's currently within the spending envelope. What the approval for the Children's Hospital,
So there'll be no additional money for redesigning the water system
there will be additional.
required from the department.
It will be within. It will be within its approval, because the approval was for, I think, 500. Let me check the number. It was about 600 million was the overall was the total, but added to that was optimism bias, which is an allowance for the tenants.
I love that phrase. I think that's an amazing phrase.
It was Blame
Yes.
McDonald. There was a consultancy project years ago which looked at why we're
So it covers all eventualities, doesn't it, really? Sort of like, I mean, in layman's terms, it's sort of set out to say, whatever you need, you'll get. Because I think that's the problem. I think that's the problem here. That's the nub of the problem in terms of these capital budgets. We continue to spend money, and the notion is, oh, well, there's optimism bias, and whatever you need, you'll get.
Optimism bias is a contingency, but it's for a fixed amount of funding, so that, and the additional funding requirements for the water remediation, etc., will be funded. It will be an additional cost funded from within the optimism bias. However, it is a finite amount. It is not a blank check. If the expenditure requirements go above the optimism bias allowance, then the project will have to come back for a business case addendum for approval, and this will have to go through both the department and through the Department of Finance.
Okay. In terms of this contingency planning envelope that we now have for capital build, how much money in that is going to go towards fixing the problems in the new maternity hospital? And there's a headline in the paper the other day that the new maternity hospital is costing £124,000 or £5,000 every month, I'm going to say, for nobody to be in it. So how much of that capital allocation is going to that, and how much of that is coming out of trust funds?
There's an additional allocation of 1.7 million this year for the maternity hospital remediation works.
Okay, so 1.7 million this year. How much have you allocated for the following years, when we are told that the works to the maternity hospital won't be finished until 2028?
We are.
And how much is that in total over those years?
An additional £2.4 million has been bid for the 27-28. Yeah.
So 1.7 million this year, 2.4
next year.
For next year. So we're considerably up on that. Is that, do you foresee that being the end of the bids for and is the running cost of that 124,000, is that a trust cost or is that a capital cost to the department?
Well, the capital funding is being funded by that is the amount that the department is giving in respect of its capital funding. I don't know. I can't speak in terms of the resource funding whether they're receiving anything more for that. I presume it's not.
No.
I presume the trust is.
They'll have to fund it within their own basin.
Yeah.
I mean, that's another 4 million odd. Yet, and this, I know it's on all politics is local. I suppose my great gripe is that we can't get $1 million to start a visioning plan for a new hospital at Craigavon. But we are continuously fixing problems in the Belfast Trust. And we continue to do it without anybody being held accountable whatsoever. Do you think that's an appropriate arrangement?
What I would say is that the Craigavon Hospital, the initial phase is £14 million. So we haven't seen it.
I've been told that in Craigavon what they're looking for is a relatively small amount of money to actually update the visioning plan. They had a plan. It's about 10-year-old now. It's not where it needs to be, and they wanted funding to actually bring that plan up to date so that they, when they came to the 10-year capital allocation, they were in a position to put something credible and coherent to the department. Is there any, have you heard of this funding? No?
Certainly we don't have a bid for that as part of the capital plan.
Well, I am meeting the trust tomorrow and I will ask again about it, but that's my understanding of the position. I have written to the Minister on a number of occasions and he has declined to make that money available. But we are in a hospital from the 1970s where in the middle of a storm a year ago the windows blew in around patients. I'm a bit frustrated that that's where we're at, and I would like if you can investigate that and come back to me, because I think it's really, really important. I would like some information on Encompass, and I'd like a total amount that the Belfast Trust are actually looking for in terms of all the repairs to the buildings, that including the mental health unit in the grounds of the City Hospital, and the actual money that's required at Knockbracken to transfer patients out of the mental health unit into Knockbracken in order to make that suitable for those patients.
Most of those costs are being funded from the Trust General Capital Allocation. They're not representing an additional bid. They're not getting a specific allocation for
those. Those are coming from Trust.
From the 50,
yes, from whatever you're allocating to the Trust.
As a general allocation for minor works, etc. We're expecting it to be funded to give that challenge and to sort of say, well, it's coming from your budget, so therefore that's to encourage you to minimise the cost as much as possible.
And Paul, just my final question on this, because I do think this is important. We have just had a fortnight where we've had 2 inquiry reports. We've had the last 2 years report after report after report about the Royal Maternity, the mental health unit, all the other things that have gone wrong. But nobody is accountable, not the health estates team in the department, nor the trust. Nobody is accountable for all of this money that is being spent over and above what should be spent. Nobody is accountable. Nobody has been held to account. I haven't heard of anybody being held to account. Is the Trust Estates Department, Health Estates Department, the Department's Health Estates Department doing any work on that issue of accountability and that money that is just seems, with the optimism bias, you can ask for whatever you need.
Well, again, the optimism bias is a finite amount, so it is not as you just ask what you need. All expenditure is subject to business case approval to ensure that it represents.
That's not what I asked. Is anybody being held accountable?
That is how public expenditure is held accountable in advance of it being incurred, and then.
So, since it has gone so far astray, is anybody being held accountable for that?
That is not within my remit, but I can assure you that colleagues in health estates take this very seriously and are scrutinising.
But I've been told that now for 2 years, Paul. I've been told that for 2 years, and I haven't got any answers on that issue of accountability.
Okay, I don't think we're going to get it today either. So, thank you very much. That has been as depressing as we expected it to be truthful. But thank you anyway for coming along and taking our questions. Okay, members, we're going to move on to item number 9, oral briefing on gender services. So can I just refer everybody to page 81 of our pack.
Chair, just when we're waiting for the changeover, is it possible for the committee to actually just inquire about the total costs of Encompass?
We're going to
in advance to warn them
absolutely.
That is a really important question, because I hear figures of $1 billion. I hear enormous figures.
I think that they will expect us to ask questions next week about cost, about roll out, about any potential problems, about it benefit to date and its long-term benefit. So I think we need to make that clear to them.
Just to say, Chair, we've got the briefing paper in for Encompass, and it does give some detail, but we can go back saying we'd want further detail. It gives overall spend, total expenditure to date in each of the trusts and within core. But it doesn't really break it down much more than that. It just so it is. So we can go back
We'll go
and
back and say we want that.
further information on it.
Can we, sorry, just to follow on from what Diana said, can we also ask how that was matched by the original business plan?
Yes.
Because I think we've heard previously that this was an unforeseen expense, this was an unforeseen, and they just get added up and added up. So
I mean, we must have had about 20 million there just rhymed off.
Okay, we'll make them aware of that. Okay, so our guests are
interesting.
Ready for coming in? So, can I welcome to the committee Mark McGuckin, Director of Disability and Older People, Oisin Martin, Co-Director of Mental Health and Learning Disability, Paula Tweedy, Co-Director of Hospital Care, Danielle McMillan and Orla Tierney, both from the Belfast Trust. So you're all very welcome. We have received some documentation in advance of the meeting, but I'm going to hand over to yourselves just for some brief introductory remarks, and then we'll go straight to questions from members.
Thank you, Chair. I appreciate the opportunity to come up and brief this committee this afternoon on the Regional Lifespan Gender Identity Service, and I'm also going to cover some of the issues from Baroness Cass's recent review or assessment of the service. I suppose my opening comments will cover an overview of the revised model for gender identity services and what options we considered in the development of the new approach. Also update you on some recent developments regarding Northern Ireland's participation in the Pathways Puberty Blockers trial. I suppose if I start with why we believe that we needed a new service for the Lifespan Gender Identity Service. We consider a new approach to gender services was required. I suppose it's important to highlight that the services were under significant and growing pressures. The adult service currently has over 1,000 people on the waiting list. The Knowing Our Identity service, the COI service for under 18s, has in excess of 50 young people on the waiting list, and there's around 45 more likely to be in the CAM service waiting to be referred to the COI service as well. In 2020, the endocrine support for young people had to stop due to the lack of capacity in the adult endocrine team. That meant that young people could not safely transition from paediatric to adult hormone services, and this was considered a significant patient safety risk. Both adults and children's services are facing resourcing challenges and long waiting times. On a national basis, Baroness Cass's independent review of gender identity services, the Cass Review in 2024, and her own gender identity review were clear that gender identity service must be multidisciplinary, psychologically informed and consistent across the lifespan of the service. The system we currently had could not deliver that. So in terms of looking at a new approach, we covered, or we assessed 4 main approaches. The do nothing approach, which we have to do in any business case approach, that would have continued to see the waiting list grow. The patient safety risks would have remained, and it did not meet the ministerial commitments either, so that was immediately ruled out. The option 2 was to add endocrine capacity only. This would have only supported one part of the pathway. Psychological capacity remained insufficient under that approach, and the unsafe transitions remained between adult and children's services. Third option we looked at was to create a lifespan service only. That would have improved the governance and psychological care. The endocrine bottleneck would have remained under that approach, and the waiting times remained unmanageable. So the option we went for was to create the integrated lifespan service and strengthen the endocrine capacity. This was the only option which would fully address waiting lists and reduce waiting lists, address the safety concerns, improve the workforce stability, and it had the highest score for strategic fit and benefit in the business case model that we have to use. So looking at what the new lifespan service will deliver, the business case developed for the recommended option brought children's, adults and endocrine services together into one integrated service, replacing the previous siloed model. The single path removes a cliff edge at 17 and 18 where children move into adult services. and ensures the endocrine services are fully embedded. It also improved governance and leadership, which is now located in one place, and it also strengthens psychological support from the outset of the process. And a key feature of the revised process is establishing a dedicated management structure, including a full-time manager overseeing the full service. It also creates greater governance, consistent training and proper supervision, areas that have all been difficult to sustain under the current siloed model. There will also be a full waiting list validation exercise in the first 12 months of the lifespan service to ensure we understand the full extent of the level of need. There will also be staffing and capacity improvements. To deliver the new model, the proposal included the recruitment of staff into both the lifespan gender team and the endocrine team. These roles strengthen psychological care, clinical governance and endocrine capacity, the three significant weaknesses in the current pathway. With the full recruited team in place, the service aims to meet the 12-week target for adult first appointments, meet the 9-week target for under 18s, and ensure endocrine referrals are seen within 12 weeks. And the expectation is that we would reach these targets within 24 to 30 months of the fully fledged service. Therefore, when fully implemented, it is expected that the service will deliver shorter waiting times, safer supported transition from youth to adult services, re-establish the endocrine care, establish a stronger multidisciplinary model aligned with national best practice. We would have consistent psychological support across all age groups. It will improve the service user experience and will bring a clearer and more sustainable long-term service structure. I'm going to cover, Chair, very briefly then the findings from the CAS assessment of the Gender Identity Service. You'll be aware that the Minister commissioned Baroness Hilary Cass in September 25 and a number of her colleagues to assess whether the changes to the services for children and young people with gender incongruence and gender dysphoria in Northern Ireland were compliant with her recommendations from her 2024 review. The team who came over with Baroness Cass included Dr. Camilla Kingdon, Dr. Julie Alderson and Professor Judith Ellis. The team met with clinicians and the clinical teams within Belfast Trust, the Child and Adolescent Mental Health Services, paediatricians, service users and social services colleagues as well. Baroness Cass identified some strengths to the integrated approach. She noted that strong integration between child and adolescent mental health services, clinical teams and social services. She noted a good foundation for the lifespan model, and she also highlighted that new funding presented a major opportunity to rebuild endocrine services within the Trust and across Northern Ireland. Baroness Cass's report contains 6 headline recommendations. She recommended that we introduce shared clinical posts with CAMS and other under 18 services. They recommended the strengthened integration with paediatrics. She recommended strengthened clinical leadership, the provision of training and a holistic assessment framework and core data set, that we adopt the standardised psychoeducation programme for informed consent, and we establish an MOU with the National Power Network for Hormone Decision Making. I suppose following that, a brief update on where we are on the clinical trials. The CAS review in 2024 found that there was not enough reliable evidence to support the routine clinical use of puberty blockers for young people with gender dysphoria or incongruence, highlighting potential risks to neurocognitive and psychosexual development and bone health, and therefore advised that their use was only used within research. Based on further expert advice, the Minister sought and secured executive agreement in December 24 to introduce an indefinite ban on private prescribing of puberty blockers for under 18s in Northern Ireland. The UK Pathways trial, which was granted regulatory approval in November 25, was created to fill the evidence gap identified by Baroness Cass by studying the effects of puberty-suppressing hormones on cognitive, physical, social and emotional well-being through a randomised controlled trial. Eligible participants for the trial must have an ICD-11, which is a condition related to gender identity-related health, diagnosis of gender incongruence for over 2 years, have engaged in other forms of care, be assessed by both their clinical team and a national multidisciplinary team, be over the age of 11, in early to late puberty, and be under the age of 15 years and 11 months. It was envisaged that around 226 young people across the UK would be recruited over 3 years beginning in early 2026, with the trial being led by King's College London, with funding from NHS England and the National Institute for Healthcare and Research, and that funding was totaling around 10.7 million. Minister Nesbitt had previously intended that Northern Ireland would participate in the clinical trials and research programme, having received assurance from the former Secretary of State Wes Streeting that children in Northern Ireland would have equitable access to the trial. In December 25, a number of campaign groups initiated formal judicial review proceedings against the Health Research Authority and the Secretary of State for Health and Social Care. The case is currently still progressing through the courts, and provisional date has been set for substantive hearing next month. In February 26, having considered the context and ongoing concerns, Minister decided to suspend Northern Ireland's involvement in the trial until the legal process is concluded. If the trial continues in the future, following the conclusion of the JR, the Minister said that he would consult executive colleagues before reconsidering Northern Ireland's participation. The welfare of young people remains his priority as part of that consideration. Minister Nesbitt's decision was subsequently followed by a UK-wide pause on the 20th of February after the Medicines and Healthcare Products Regulatory Agency wrote to the King's College London regarding the safety and well-being of the participants to be recruited to the Pathways clinical trial. In summary, and covering what I've covered before, Chair, the Regional Lifespan Gender Identity Service is a major step forward for gender identity services in Northern Ireland. It modernises the current pathways, addresses long-standing safety issues, and builds a structure capable of delivering timely, compassionate and evidence-based care in this area. We are grateful for Baroness Cast and her colleagues for conducting the assessment of our gender identity services, and we're carefully considering her recommendations. As I've already noted, Northern Ireland's participation in the puberty blocker clinical trial remains suspended pending the outcome of the review on the judicial review in England. As I said, any future participation will be brought to the executive before a decision is taken. And we're happy to take any questions or comments, Chair.
Thank you. Just in terms of the new services, can I ask the kind of interaction between family, service users, advocacy groups in co-designing or planning or helping out shape the new services?
Yeah, there was a group, and Paula may be able to give you more information on that, Chair. There was a group set up which had a number of interested sort of the groups representing that sector were part of that group to come up with the planned new approach. There was as part of that approach that a model was brought forward to the department which would have cost more and addressed a sort of, it would have been a larger approach in terms, or a bigger approach in terms of the service required. We went backwards and forwards with that group. Paula will know the exact name of the group. We backwards and forwards with that group a number of times to come up with the revised model, which was then approved. But Paula probably knows more detail on
the
it.
Gender Identity Liaison Panel. There were two groups that, when we were designing, when we were looking to see how we would move forward with gender identity services, we had a review group, which were clinicians, primary care, PHA, and representation from clinicians within the trust and nursing within the trust. Then there was a separate group that was the Gender Identity Liaison Panel, and we actually had asked for, there was a piece of work done where people were allowed to apply for that and were interviewed, and there was a group represented from that came forward, and they joined. They give us our stakeholder engagement as part of that group. But as part of that group, we also continued to include people from trust colleagues, and were included in the liaison group as well as departmental colleagues, just to get a complete overview of what was going on. So there was lots of participation and lots of meetings with representatives from all sides, really.
And sorry, Chair, the Minister has also met with a number of families when the decision was taken to remove Northern Ireland from or the indefinite ban. Minister did meet a number of families and representative groups at that time as well.
Okay, and Mark, you said just towards the end that the new service is a major step forward, modernising. So in terms of improvements that patients can expect to see as a result of the new service, could we outline exactly what those are? what improvements, what people should expect to see across the kind of care, and ensuring that there's equity of service across the north.
So the new gender identity service, there'll be recruitment for 2 psychologists, because that's to strengthen the psychology and integrated approach there. Service manager who will look across both services and ensure that there's transition governance arrangements. They will keep an eye on both sides of the service. A number of additional specialist practitioners, a consultant endocrinologist, because that's an area that Hilary Cass raised was an issue with ourselves, which we were aware of. Additional nurses, pharmacy technicians, and administration and secretarial support, because one of the lessons we learned from the stakeholders were getting contact into the service was often difficult, and they had asked, when they wanted to raise questions and things, they wanted to have access to that. I think Orla might be able to advise if there's anything I've forgotten there. I think that's it all.
Yeah, I think it is that holistic treatment pathway that we weren't able to fulfil because of the deficits in the adult services. So it's the oversight of a full pathway for across the lifespan.
And you will remember that our current services are part of our CAM service. Our children are part of our CAM service anyway. So children, when they initially are assessed, go through full CAMS assessment before they move into the gender identity service. So that helps support right from the very start through mental health services. And we were very clear, and actually Hilary Cass admired that with our service, because I'm not sure that was completely in place in England, although they are moving towards that. So it was really building on what we already had.
And the child will remain with CAM Step 3 while they're with the gender service, and that service will remain, and that all of their holistic neurodevelopment needs are explored as well.
In terms of funding, because the department have just left in terms of providing a bleak outlook for funding. So is funding, how long is funding guaranteed for the service at the level, and if there was more fund available, could you just do more?
Well, this was always step one. It was always going to be, we knew when Hilary came and Baroness Cass came that she may suggest a few other posts which we don't have funding for. So this was almost phase one of what we needed to do to get our lifespan model in place and put both for paediatrics and adult services the core services that need to be there. Moving forward, once these posts are in place, we will need to look at other areas that we know may need to be expanded in the future, and that would be further integration within paediatric services and a connection within paediatric services, a further connection because they're already, Belfast Trust obviously holds our children's hospital there, and the paediatricians have been involved in some of the discussions, and potentially a bit more expansion within endocrinology and our CAM services. But we will grow this service. We're at phase one. We have to see where we are now and then work out what needs to be done going forward.
And it is recurrent funding, Chair, as well. The initial funding was 806,000, but that is recurrent, and that will increase with pay rises and things like that as we go through. So the initial funding was 806,000, but that is recurrent funding.
Okay, thank you. Dan?
Thank you, Chair, and thank you for the presentation. Just going back to an issue the Chair raised there about co-production of this model. Since the Rainbow Project essentially leaked the issue or announced it, I'm presuming the Rainbow Project were integral to the co-production of this model?
They were one of the members of the liaison group, yes.
Okay. And I suppose the second then, just to follow on from that, your briefing paper says that the lifespan service model, I'm quoting directly from it, is not a gender affirming service. A referral to an NHS gender service is not gender affirming. Given that much of the people, or many of the people who engaged in the co-production of this, how do you ensure that it's not a gender affirming service, and what do you understand by a gender affirming service?
I maybe offer a remark at the outset. I mean, I would address this answer from the context of my current role in SPPG, but previous experience in CAMS in one of the region's health and social care trusts. The care pathway set out
excuse me.
In Baroness Cass's recommendation has several checks and balances throughout the care pathway in relation to maintaining clinical objectivity throughout. It is not a rush to any sort of conclusion. Parents are taken through a very sort of considered series of engagements around psychoeducation support. These crises that children run into are very real and very urgent, and I've spoken to a number of parents over the years who find themselves at a loss as to what to do to offer advice and guidance to their child when they're negotiating a difficulty to do with gender. And frequently you have to impose a sort of biopsychosocial model at the outset and understand the child's biography and around. Many children encounter trauma over the course of their development. There could be other factors at play to do with anxiety and depression, neurodiversity, social influences could be at play, and you've got to very carefully work through those issues in a way that doesn't offer any sort of affirmation to go down a sort of gendered pathway. I suppose the second thing I would say about what assurances are within the system, this suite of proposals takes the Gender Identity Service from being a fairly niche interest within the region to being a much more expansive concern. The fresh posts coming online will broaden the sort of professional discourse in and around cases as they sort of go through the system. And it's always been my experience working within that sort of clinical network in CAMS that plurality of professional roles adds to the objectivity. You have people running things past each other in a way that offers plenty of checks and balances and second opinions. So, I think I read through the CAS recommendations and was really heartened by what I was reading, and thought back to those conversations I'd had in the past with parents who found themselves in a very bleak position. The final thing I would say, and it kind of develops upon a question posed a few moments ago by the chair, what improvement will this make? It'll certainly strengthen the safeguarding arrangements. It kind of mainstreams the gender discourse into a wider conversation involving CAMS, involving primary care, secondary care, endocrine medicine specialists and paediatricians. Within that context, you're no longer confining sort of nuanced decisions around children being at risk of harm with one or two people. It's a much more porous professional network. So I think that's really one of the big benefits.
I'm not going to labour that point because I have quite a number of other questions I do want to ask. I too read the CAS review. She identified the children that were referred as often being children who had been abused, involved in trauma. I have no doubt, and I have every sympathy in the world, that some of these children are in need of our help and our guidance. I disagree intensely with the experimentation of children with puberty blockers. I disagree intensely with that. And I think that these are things that are irreversible, and that we are doing this at a very, very young age to children. When you consider that our government is now actually saying that a young person at 16 is only eligible to have a TikTok account, but actually the new guidance issued at the end of last week tells us, well, actually it's okay to give puberty blockers to a child, a young girl as young as 11 or a young boy as 12. I just think in that case we have lost our moral compass. That is my view. It's not a surprise to anybody in this room, but it is my view. So it is just, I am very concerned that children referred to a service should not be referred to a service that is going to be affirming something that a very confused, traumatised child and traumatised parents would be in the middle of. And my heart goes out to some of these children. I think that they're in very, very difficult circumstances. So can I do think that the issue of gender affirming is hugely important.
I maybe just provide a little bit of clarity about that a referral to the service, the sense of is not gender affirming, and I suppose that and probably that one of the strengths of we had an existent service. What our concern is that we safeguard the health needs of a group of young people and adults, but just from an assessment and a formulation point of view, the service at the moment works on a consultative basis, so you will be a core CAMHS patient, as well as there will be a referral to COI, and in the first instance that's only on a consultative basis, so there will be a full workup of a child's formulation driven by multidisciplinary team. So they would be looking at neurodiversity, their developmental stage, mental health, past trauma, and I suppose there are relatively small numbers from referral rate that would then go on to there isn't puberty blockers at the minute, and there's been a ban on that, and we haven't used them since 2020, but there's quite a small, for want of a better word, conversion rate, less than, I think it's about 18%, so 82% of young people are finding out about themselves and their identity, and they are then supported through that, through a multidisciplinary team. So one does not arrive at that decision.
That's a brilliant segue into my next question.
You don't arrive.
Absolutely brilliant.
It doesn't confirm that you're come to this team, and
so I actually have written to them, or had asked questions of the Minister about those young people who in Northern Ireland in the past had been prescribed hormone treatment, and in the answer has come back that in 2019 there were 9 and in 7 in 2020. Can anyone tell me what age the youngest child would have been that would have been prescribed those puberty blockers in either of those 2 years or even in the past?
We don't have that individual data at the moment, but we can certainly come back to you on that age group of those individuals that were prescribed at that time.
Okay, so I do think that is important, that we understand where the service has come from and who actually, and what age those children were when they were prescribed hormone treatment in 2019.
From a clinical point of view, it wouldn't be until we were approaching puberty point, and then the upper age limit is 15 years and 6 months. So the lower age range depends on the child's developmental stage.
But we would have data which tells us what age those children were.
Yeah, so I think the data that you're referring to was the cross-sex hormones. Is that yes? So there was, as you rightly said, there was 9 in 2019 and 7 in 2020. So that's separate. They're separate prescription to the puberty blocker. So that would be the second course.
So can we know the youngest age that a child started puberty blockers and the youngest age that they went on to the further treatment?
So the puberty blockers would be prescribed as a first line, and then you would progress to the cross-sex. So that data relates to cross-sex.
No, I'm aware of that. But I want to know, what was the youngest child in Northern Ireland when we were prescribing these under the system that was prescribed puberty blockers, and of those 9 and 7 children, what age were they when they were prescribed cross-sex hormones in 2019 and 2020? So we understand where the services come from. I think that that's important. Can I also ask another question, because it interests me, as a further stage of transitioning, what's the youngest age that there has been any surgical intervention on children?
There's been no surgical intervention
under the age of 18.
Under the age of 18, we don't have a currently have a pathway for that.
That's okay. So what happens? So we have a young traumatised child and traumatised parents who enter the programme and they proceed to puberty blockers, maybe cross-sex hormones, etc., etc. What happens to those young people who maybe at 18 or 19 say, this has been a terrible mistake and I shouldn't have done this? What is the pathway for those young people?
We haven't come across any cases of that at this point, so I suppose it would be taken on a case-by-case process, but we're fortunate that we haven't had a case like that.
What would be the pathway then if that happened?
I suppose that would have to be a full multidisciplinary team meeting to discuss the next steps in that patient, that young person's treatment journey.
For example, has that young woman's fertility been irreversibly damaged by that stage?
As part of that process, fertility is discussed, and at times there is conversations around storage of fertility at the time before starting on hormone blockers.
Do you believe a child, because the new guidelines for the King's College trials starting, and they're hoping to recruit on the 1st of August, barring any legal issues, says that a girl age 11 and a boy age 12 can be part of the trial of puberty blockers. Do you believe an 11-year-old or a 12-year-old can make that decision?
I think we have to be led by whatever the evidence base is at the time, and I think it is right, and certainly whether or not children going forward will be involved in the network, the research trials would be a ministerial decision, and we would...
But that's not... I understand that's going to be a ministerial decision. I get all that. I understand that. I'm glad we were able to push the minister to that position, actually. But what I'm asking you is a set of professionals who deal sympathetically with children who are very traumatised. Some of these children may be neurodiverse. In fact, many of them are. I'm asking you, do you believe those children at age 11 and 12 can give an informed consent and say, this is something I want to do, this is something that is irreversible and something I want to do?
I don't.
I'm just asking, because you're the people who are working on this. I'm not. I want to know if you believe that those children can give consent.
I think the answer to that hinges upon the individual characteristics of each child. Yeah. I think it's also important to take stock of the fact that there's a qualification to involvement in the Pathways trial of a 2-year period of having had gender incongruence as a core belief set. So, you know, by the time children are in that position, they will have been experiencing thoughts around gender dysphoria for a significant period of time. And
if we take that to its logical conclusion, that means that child at 11 who is eligible for the Pathways trial would have to have started having thoughts about their gender at 9. My grandson is 9. He's talking about the World Cup, and you know, like, I just think
I appreciate the strength of feeling.
I'm worried. I am. It's not only a strength of feeling. I am worried about this. I am worried for our children, and I am worried for our most vulnerable children.
I think the fact that our services are very much within the CAMS service, so a child starts in CAMS in this process even before they would be referred to the gender identity service. I think at that stage they're being supported by CAMS all the time. And what the funding has allowed us to do is to put governance and additional multidisciplinary steps in a process that wasn't there before. So what that has allowed us to do is to ensure that our children are being minded throughout the process without, as Orla has said, it is not gender affirming. We're there to assess the children as part of a multidisciplinary team. The staff, you know, are very experienced in this, and they will receive additional training as part of the assessment tool and ongoing training. And I think, you know, that as a health service, that's what we have to do, protect the children, and the safeguarding that goes into this is part of what's happening. So
supporting those families who are, and parents that are clearly struggling with, don't think we'll resolve beliefs or the moral argument in here today, and our concern is that the health needs, and in the absence of a service designed to support those health needs at the time that they need it, and have a multidisciplinary driven formulation about a child that considers their neurodiversity, considers their psychosocial functioning, considers their family and previous trauma and so on. In the absence of that, our children are more at risk. So I don't think anybody is making fast and loose decisions about child health, or decisions that they may later think that they wish they hadn't have made. So it is very serious business, our children's well-being. Our concern is that in the absence of a fully functioning service where people do have the necessary expertise, our families and young people are seeking that health need gap to be met somewhere else that is that is not regulated, and certainly we are coming across families who are seeking private prescriptions and stuff. So I think to have a service that is is expert, is dedicated to the well-being of the child and their family that they're in, is a safeguarding mechanism that we ultimately can't afford to not have the service. And again, having the service does not lead to decisions that are not thought out with the child and the family and all of the package that comes with children and families. Adults is maybe clear cut.
I know that the chair's going to shout at me any second now. I do know that. I just want one more question. The current position in Northern Ireland is that we are suspended from taking part in the trial. The trial has now had new approved guidelines, even if I think it's really completely, it's beyond me to even think about it. But what will your recommendation be to the Minister if there are no legal objections to it and the trial does start to recruit on the 1st of August?
I suppose.
And what will Northern Ireland need to do to be part of the trial?
I suppose that's a bit of a hypothetical question, Diane, because we don't know the outcome of the judicial review and what the judicial review may bring. So it'll be very difficult for us to say what advice we would give the Minister.
Everything being hunky-dory with the judicial review.
I think we have to look at the clinical guidelines that come out on this, Diane, and we will put advice to the Minister to say, based on what is said in terms of the safety of this, balanced against the risks of not participating in the trial as well, and put that balanced argument. As you would expect me to say as a civil servant, we will put all sides to the Minister for him to make a decision. The Minister has said, and is very clear when he removed us from the trials, that he would put this to the Executive for an executive decision. We'll also take advice from the Chief Medical Officer, as we did previously, and the Chief Pharmaceutical Officer in terms of that, because that was what the decision actually to bring in the indefinite ban on puberty blockers was based on. It was based on that clinical advice as well. So we will take advice from clinicians in developing that advice to the Minister. That's probably not the answer you want, Diane, but in the abstract of not knowing what's happening.
I fully accept and respect your position, Mark. I'm not asking or pushing you to do anything other. I have read the recommendations in terms of the new requirements around the trial. I have read the conditions in which the trial would be stopped on any young person, including issues like effect on brain development, bone density, vaginal bleeding. There's a range of issues. It seems to me that this is a very risky experiment on children. Can I just ask, Mark, I tabled a number of questions in February and in March on this issue which haven't been answered.
I will take that back and see where they are now.
Thank you, Chair.
Yeah. I mean, there's full of risk within our health service every day, and it's vitally important that clinical guidelines and the well-being in this instance of our children and families is uppermost on all our minds. Danny?
Thank you, Chair. Yeah, and I was going to agree. This should be about the children and making sure that children are treated as their medical professionals decide what is best for them, because that is a course of treatment that is being decided, and it's the children's welfare that should be considered. I'm very glad there is a service for those families and those children. It's a small amount, a very, very small amount of children and families that are involved here, but I think it was yourself, Oisin, that mentioned that they are desperate, they are in crisis, and they need somewhere to turn. So I'm glad that there is a service for these families. Just to ask a couple of questions. So I know we have the questions about the trial there. Generally in UK clinical trials, children can take part in UK clinical trials if they have parental consent, if they're under 16. Is that correct?
My understanding, yeah.
So this will be no different. So parental consent will ensure that...
There are to be additional memorandum of understanding around informed consent that will be form part of, and there will be psychoeducation. There would be a requirement for us to meet quite a few standards, and one of them would be having the availability of psychoeducation for families and young person before to assist with ensuring that consent is informed, so that there's an extra level of
there's a higher
bar to pass before you would be able to demonstrate that your population could enter the trial. And we would equally be cautious about Northern Ireland's a small place, that we will equally think about confidentiality and data, so there's other considerations for us too.
And there is quite a list of things you need to have, as I said at the start, Danny, there's quite a list of other areas you have to have gone through first before you be eligible for the trial as well.
Nobody's just popping into this trial. They've had to go through a long process of medical professionals judging that they've met the criteria to be eligible for this trial.
Yeah, and the aid memoir attached to that sort of modular provision of psychoeducational support very carefully sets out the requirement to have discussions at various intervals about the finality of some of the medical interventions that could occur much further down the care and treatment pathway. And there's also a very clear direction on offer to clinicians to ensure that their discussions are gender neutral, non-affirming, but they offer a platform for parents and for children to explore ambiguity and uncertainty, and to sort of develop ways of talking to each other. I think that's one of the things that really parents struggle with. There's no blueprint for a child who out of the blue starts to experience gender dysphoria. How do we have those conversations safely? So parents really need support with this as well.
I can imagine, they're finding it very hard when there's nowhere to turn to, but there is now a service, so that's good. With professionals at each stage.
The recurrent question I remember being posed when I worked in CAMHS was, can you outline what the Trust's relationship is to private prescribing?
Sorry, say that again?
Can you outline what the relationship of the Trust is to, or what the attitude of the Trust is to private prescribing, i.e. if we go and get the hormone treatment, will your CAMHS service fall in line and provide the monitoring and the support in the background to carry that forward safely? And of course we don't. I mean, that wasn't something that was on offer.
Families are willing to step outside.
Some families.
The medical process if they don't get the care, if they're not able to get the care that they need.
We know that's happening in the absence of the since we stopped prescribing.
It's been 5 years, since 2020 there's been 5 years, and the families are doing that. This trial will build evidence, clearly. It will have an evidence base for the use of these drugs in the future, so it will help to inform the discussion later on in many years when we're coming up to it. I think that's very important. Clinical trials are very important for building that evidence base, and the trial will be stopped if there's any injury, or if there's any hint of an injury or any evidence of injury, so the children will be well monitored, they'll be kept very safe.
It's probably worth noting that the puberty blockers, the evidence is around the reversibility. So some other hormone treatments, there wouldn't be the same level if you go on to have cross-sex hormones, but at that level and that very close monitoring, I think is critical. So there is you can stop and revert back, as it were. And I suppose the trials, the focus of that is, I appreciate Baroness's Cass's comments on it, but it is to try and strengthen the knowledge around that.
And at the minute, the ability for children from Northern Ireland to go onto this trial will hinge on that legal case that's taking place next month.
Well, it'll hinge on the legal case, and then the minister's committed to bring it back to the executive, Danny. So it's a legal case, but also a political decision whether they Northern Ireland take part in the trial or not going forward.
Okay. With this service, is there service user engagement? I know you've mentioned people who have been through the service before, so obviously there's the families that have been through this, service users that have been through this. Is service user engagement, is that embedded into the service at the minute?
With our new lifespan, we do have lots of contact with service user populations and the service user voice. Certainly our plan is that we will have a service manager for the post in place in the near future, and they will drive that entire stakeholder engagement, including service user and care advocate, where we're talking about young people.
I suppose, as Paul said, the first phase of the funding, it didn't include the peer support worker, but in phase 2 we would be looking to actually embed a peer support worker within the actual team, the lifespan team going forward.
Thank you, Chair.
Amanda?
Just a very quick point. Definitely don't proclaim to be an expert in any of this, but the small number of families, and they are tiny, 2 families I think I've ever been in contact with, who had young people, didn't come from abusive backgrounds. I just think it's worth saying that. They were not traumatised until they got to a point where they wanted to declare who they felt they were, and the traumatisation came from others not accepting that. And that is the point at which they needed, and I'm going to say probably, Oisín, your service. So I just think we need to be careful with the language. We've talked as though all these children are traumatised prior to making these decisions. They are in a lot of cases abused. Is there any evidence to suggest that that is the case? I'm not sure. I'm not aware of any, but maybe I'm wrong.
I don't believe so. The neurodiversity, there be a high prevalence of neurodiversity, but in terms of trauma backgrounds, we don't have that research, but I don't believe so, sort of anecdotally. No.
Yeah, and just in terms then of the family support that you spoke to Danny about, I mean, I think that is really, really important, because it is difficult for a family, because there are all sorts of questions. It's challenging, it's massive stuff, I can't even begin to imagine. But where families maybe disengage from the young person, which I have also experienced, where the young person has been asked to leave the home at quite a young age, is there any way of reaching out to those families to support them to maybe try and rebuild that? Is that something that...
Well, that is something that would happen within our COI service, so that all that psychological support, that psychoeducation support with families. Obviously we can't comment on individual cases, but where there would be a sort of outreach to families where
even if they've disengaged from the young person, they'll be offered that. Obviously you can't force them to engage.
That's the role of the practitioners within those teams, to work as a family, systemic family. Yeah.
There would also be family therapy services available through core CAMS. So certainly if there was evidence that a family were struggling on a systemic level, that would be part of the overall core assessment, and there is provision within the core network to attend to that, albeit it's under a massive strain in terms of waiting lists.
Understood. Thank you. Appreciate that. Thank you, Chair.
Daniel, briefly.
Thank you. The CAMS referral bit, now certainly I'm aware of a family that were referred into CAMS and then discharged before they got into the Knowing Our Identity service, and that seemed to be a barrier, being discharged in getting into Knowing Our Identity. So if the children don't need mental health support, if they're not suffering from anxiety or depression or any other mental health issues, do they need to be within CAMS in order to access Knowing Our Identity?
The referral has to come from CAMS, so they have had to undergone a period of work with core CAMS to establish that full psychosocial, biosocial assessment. It may be on, maybe thinking it's maybe on where they have then been referred and they're now being held within CAMS, because the feeling is that the majority of the work can be done psychologically through the COI service. That may be the scenario.
They're always kept there. They're always that level of service is always kept around them.
Yes.
It's a safeguard, and I think it's a feature of the arrangements in Northern Ireland that Baroness Cass found to be very positive. But were you posing a question there about a family who'd been referred into CAMS and then discharged from CAMS? I can only surmise then that either at triage or at point of formulation it was determined that there wasn't a requirement for ongoing referral to a gender identity service or COI.
In a normal case, they'll be kept with CAMS the whole way through.
Yeah.
Our CAMS, core CAMS, will have the availability to consult with our Knowing Our Identity service. So they will say to the child, and there can be consultation in the background, and a direct, referral onwards isn't necessary.
Thank you. Thank you very much.
Okay, thank you all. Very useful. Appreciate the comment.
Thank you.
Members, down to 4 members, so we're just going to push all the remaining business to next week. We'll be glad to hear. So, I mean, there's just a written briefing and then correspondence in the forward work programme, so we're just going to add that to next week's agenda if everybody's content with that. Yeah. Okay, so just wait for them to go and then we'll declare the meeting formally over. Okay, so last item is the date time of next meeting.
It's Tuesday, so what is it?
Sorry, Chair, could I raise something under any other business? No? We're done?
Decisions, so we can't.
I wanted to raise something too, so
you wouldn't lie.
I can't allow myself. So the next meeting is Thursday, Tuesday.
No, it's Tuesday at 9:30. So it is to meet with the Spotlight mums.
Oh yes, of course, absolutely. That was in the forward programme. So yes, so we're meeting them Tuesday at 9:30.
Where's that, sorry?
Room 30. Oh no, room 29 in Shaw. So meeting is adjourned.
Thank you.
Alright, we can't because there was things I wanted to raise too.